more in the list, so I think he'll take a couple of minutes.
Yeah, we'll wait for him.
Yes, sir. Yes, sir.
Chandrasekhar, can you check with Darshan what has happened?
Yes, sir.
Maybe by the time Darshan comes back, shall we start the discussion, Ashok and Jimmy?
Yeah, I think, can you hear me?
Yes, yes.
Hi, Ashok.
Hi.
So nice to see you.
And Rakesh is there and Azad is there. So can we
hi,
start
Rakesh.
the discussion? Yeah.
Good morning, sir. Good morning.
Good morning, Rakesh.
I thought that so far, Darshan's presentation was absolutely excellent. Extremely informative, delivered in a very nice way.
I think the acronyms are very interesting.
Very interesting. The Snoop, the Snoop is very good. The PIN is very good. PIN was what? P for MRI for pressure. And I for, I forgot. Infection. And N for? Neoplastic, I think. That's right. That's right.
If I just sort of ask a general question to all of us, when would you really get alerted that this headache is secondary in your clinical practice? How do you rate the various things in clinical practice? Ashok wants to say.
I use Wadia's law. Wadia's law says very clearly that longer the headache, longer the time.
I think Darshan has joined. Yeah. So Darshan,
Wadia's law is very simple. Longer the headache, less you worry.
That is true. I completely agree.
So,
Agreed. Completely.
After the headache, then you don't go to sleep till you solve the problem. That's what his law is.
Yeah.
Don't go to your room. See in the ward till the problem is solved.
Correct. Absolutely.
Sorry, sir, there was a technical difficulty.
No, there is no problem. You finish.
Carry on. Yeah. Waiting for you.
Yeah.
Actually, from where to start, sir?
From where you left off. Yeah. From where you left off.
Actually, I don't know exactly.
Hey, continue. This we have seen.
Thunderclap, you had finished. Yeah.
You have finished Thunderclap. You finished
RCVS, you finished.
Yeah, this you finished.
IIH you finished. SIH you finished.
Yeah. No, this I didn't. I think
this some of this will come in my presentation.
Yes.
Okay.
Yes.
I think you were on the MRI.
Yes. Sir.
MRI of SIH. So that you can tell.
Yes. So it can be a subdural fluid collection. Here you can see in the right side upper corner image, or there can be enhancement of pachymeninges. There can be engorgement of venous sinuses. that is also sign of reduced pressure inside the brain. Pituitary enlargement or hyperemia, here you can see, or sagging of brainstem or sagging of splenium of corpus callosum, that can also be a characteristic signs for SIH. There is a scoring system. First three are the major criteria. Next three are the minor criteria. Higher is the score, higher probability of SIH. There is also a measurement, some values. That is, if there is a mammillopentine distance, that is between the inferior aspect of the mammillary bodies to the superior aspect of the pons. If it is less than 6.5, then it is significant. Here it is 3. And the pontomesencephalic angle less than 50. It can also be a characteristic for SIH. So recommended MRI sequencing for evaluation of thunderclap headaches for T1, T2 sequences are especially for structural lesions or blood products, flare or contrast flare for PRESS, RCVS, SH, gradient echo for hemosiderin deposition, subtle SH or microbleeds, diffusion weighted for stroke or PRESS to look for vasogenic or cytotoxic edema, MR angio to rule out any vasoconstriction or arterial dissection or aneurysm, MR veno for ruling out cerebrovenous sinus thrombosis, T1 contrast axial sagittal coronal for looking for spontaneous intracranial hypertension in CSF leak, and T1 fat saturation with contrast to exclude arterial dissection. To take home that clinical history is paramount important. You should look for red flags for secondary headaches. Imaging is invariably essential to exclude secondary cause, and not otherwise specified is not an acceptable diagnosis, particularly in terms of headache. So headache, usme bhi headache.
Lovely.
Super.
Lovely.
Very
Maybe-
nice, Darshan. Very nice. Really nice.
Thank you.
So if you wanted to turn the slides off, we will
Yes.
have the discussion.
Yes.
So let's come to the discussion where we started. So longer the headache, lesser the likelihood that the intermittent nature also you would put importance to.
I'm not so sure.
Jimmy?
You should not argue it. It's less important than duration. Intermittent headaches can be there in so many brain tumors. I've seen them. And some days they tend to complain more, some days they tend to complain less. Brain tumors are one thing that goes wax and wane a bit over a period of time. They may be subacute, they may not be that long as the migraine tension type, but I'm not so sure about intermittency to ignore. Yeah, intermittency makes it more likely to be a primary headache syndrome, but I'm not so sure to ignore serious disorders.
I generally ask this question in between the events. Are you completely okay?
Okay. Good
And then
point.
if they say completely okay, then I'm a little more
Completely okay
easy.
is okay.
Agreed.
Acceptable.
Agreed.
Any other points that we actively search for? This change in character of the headache, which has been mentioned so often.
That is major point, because migraine is so common and brain tumors are so rare. So many people with brain tumors can well have migraine, primary headache, can well have a primary headache syndrome. So I think the change in character. But how do you say it in Hindi or Marathi? Please tell me that. I find that difficult. Try it out. Suppose I'm a Hindi speaking person. Ask me about change in character. I've had my difficulties. Try it out.
Actually,
How would you ask me?
I have one or two
in Hindi,
comments here. In first, I asked them, "Darad kaisa hai?"
Okay.
Kis type ka hai? Pricking, throbbing, burning, shooting, band-like. And very frankly, a lot of people cannot tell me what is the type of it.
Yeah.
So then the change, ascertaining the change is not that easy. But then I ask a general question, do you think kuch badal gaya hai?
Exactly.
And that they say, kuch badal gaya.
Yes. No, what I say is, you know,
So you leave it open. You leave it open.
Yes.
no, Ashok.
That's not a bad point. That's not a bad idea. That's right.
No, what I say is, look, you know, just think of the headache, you know, 2 years ago, 6 months ago, the headache that was there then and the headache that is there now. What differences do you find?
Correct.
You know, and some of them can sort of specify, well, it is more severe or it is this or that, you know. So I think that can be one of the things.
Also, one other question is, what brings you to me today? What has changed?
See, there is an editorial that says that why is an individual, why is it that an individual who's had a 20-year history of headache and has destroyed and spoiled this quality of life, why does he come and see me today? And that editorial is frankly convinced that there is some other factor in that person's life, whatever it is, fight with a wife or fight with a boss or something like this, that has made him absolutely miserable and made him come and see a doctor.
The coping up phenomenon and visit to a temple.
Yeah, that's a great point to discuss. I don't think there's an answer. We don't have an answer to that yet.
No, but there are a lot of people with Rakesh, go ahead. Yeah.
Sir, I always find it very difficult to pick up the secondary headaches. I mean, once you read in the continuum, they look so nicely defined. But when you go to the clinic and try and pick it up, I mean, I always find it difficult. I mean, I always feel that if there is even slightest change in the headache patterns or some different, it is better to do a scan and just rule out all secondary headaches. So I must have done many scans which are just normal.
Yeah.
But my friend,
I agree.
That's when I made it clear. A plain, simple, straightforward scan does not give you all the answers. Normally, most people are in a habit, and patients also come with you with a plain CT of the head, and that doesn't give all the answers.
Yeah. But Rakesh, what you point out is the difference between the botanist and the gardener. When I am in my consulting rooms, I am a gardener.
Yeah.
I mean, the headache characteristic and this and that is okay, but I still want to see a scan.
Yeah.
just like every vertigo. Okay, I have made up my mind that this may be peripheral, but I still want to see a good basilar.
Absolutely correct, sir. Absolutely.
I don't want
Sir,
to
because
do that 1 out of 100.
Because sir, the difference between the benign and the serious headaches are so different. I mean, you're dealing with the primary headache, where patient will be absolutely fine, even if you miss the diagnosis.
Yes.
But secondary headaches can be dreadful to miss.
Yeah. Also, I think in these days of MRI scan, so many little brain tumors which have just started appear on the scan, which will not give you headaches which has changed and all that. I think for early diagnosis, there is a definite role of investigation. So I think, yeah, it's the gardener botanist dilemma.
Yes.
Right. So
I think the short duration of headache and the later age of onset. You see, if a 60, 65-year-old man comes and says the headache is there only since 1 or 2 months, then I would 100% investigate and definitely maybe first get an ESR and C-reactive protein done. Because that is reasonably common, I think.
Maybe we can discuss one more question before we go to the next presentation. In clinical practice, if we had to put by order of occurrence, which are the commonest secondary headaches that we see? I mean, there was in the presentation, there was RCVS, there was SIH, there was IIH, and so many others. Practically, what do we see?
IIH normally, sir. Or a sinus thrombosis.
Right.
Also, I think subdurals would be relatively common. And
Can I be controversial?
Yeah.
Yeah, please.
Make a nuisance of myself.
No, please.
Matter.
Yeah.
How often in your practice, when a patient has come with an secondary headache, nothing in the past, everything is going on smoothly, and they suddenly come with a short duration of headache, slightly disturbing, and you don't know what's happened, and then you examine them, and then you take his blood pressure, you find it 170 by 110.
Any
And
number
then
of
it-
times.
Yeah.
Any number of times.
Good point. So, am I justified in making a statement that undiagnosed hypertension is possibly the most common form of secondary headache? Am I justified in making the statement?
I couldn't agree.
Because my friend, the headache specialist, does not agree with me. That's my problem. Because I tell him, you see patients who have failed treatment after 5 neurologists, and we see patients the first time. That's a basic difference.
Yeah.
I have a torrid fight with him in the canteen. The waiters were all wondering.
I tend to take this point well.
Thank you, Satish. You're making me feel good.
You know, from the beginning of my practice, I always taken blood pressure myself.
Yes.
And there are any number of situations where the patient has been going to the doctor. In fact, hypertension monitoring is one of the worst things, at least in the city of Bombay. I mean, they go once in 2-3 months, a nurse or the doctor ties that thing and say, "Abhi sab theek hai." And then, I mean, who was the Darshan or Hiral will remember, there was an epileptic patient, young epileptic patient. And on a routine check, the blood pressure was 220 by 160.
Oh, now.
And he had just gone to his family doctor in Pune, where he was told the blood pressure 130 by 80. Even in patients who are admitted, I think how seriously blood pressure is measured, how do they know about the auscultatory gap? Do the nurses really, are they well trained? I think there are many baseline issues about blood pressure and medicine, and headache is one of them. Would you agree, Jimmy and Rakesh? I think from time to time you do find hypertension. I wouldn't know what is the percentage, but yes, I think all of us must take blood pressure ourselves.
I agree completely, particularly in the wards.
Yes.
I think it is very common that they say that, 120 by 80, barabar hai. And when you take it, and sometimes, when I'm suspecting something is this thing, I take it myself.
Correct.
And more often than not, I think there is a difference between what the nurse has recorded and what I am getting.
Correct. That is the point. Yeah.
That is one thing. Second thing is, of course, this thing about, this blue collar or white collar syndrome, that is there.
White coat.
But the point is, in that, there definitely must be some element of that. But in that, would the diastolic blood pressure also rise up? So if somebody's, supposing I can understand someone with 170, 180 being because of, the doctor taking it. But would a diastolic of 110?
I don't think so.
No. I would also think
also fundus changes, that.
Yes.
Tachycardia.
Yeah.
Also, I find that if you spend enough time with them before you take them onto the examination table, then the white coat thing doesn't happen. If you're joked a little, if the fellow is comfortable.
Yeah.
In fact, light moments in the consulting room are the most important moments for them, I think.
Yeah. And just one thing, sorry, just one thing before I forget, this, once I had been to Ramurthy, Dr. Ramurthy, for some patient I remember. And what he would do is, before he starts his examination, he would take the blood pressure. Before, because sometimes we, check the power and this and that, and at the end of it, I think sometimes it's better to check the blood pressure before we start the examination.
And sir, that BP recording with all these digital machines and our routine mercury, I think has a lot of difference. I have seen in hospitals nowadays, because of the convenience, they just apply that the whole thing digital. When you record it inside the room with your usual one, it shows a lot of difference. I don't know. I don't rely on this digital ones.
I think machines have improved over time. That is for sure. But still, when you really suspect that blood pressure will have a strong role, I think it is better to go to mercury. But machines have improved. That's also there. Some of them are very reliable. Yeah. Right. So it's 9:35. Time to go to the next one. So Rakesh and Dr. Atish, acute migraine treatments, pathophysiology of migraine, preventive migraine treatment. Now here we have lumped 3 topics and we have given him 40 minutes. So Atish, are you okay with that?
Yes, sir.
Yeah. So do go ahead.
Sir, am I audible? Hello. Am I audible, sir?
Yes, yes, Atish, yes.
Yes. Good morning, sir. Today I'm presenting topic pathophysiology of migraine, acute migraine treatment and preventive migraine treatment. Pathophysiology. Migraine is a complex neurovascular disorder that affects 12% of the general population. The activation of the trigeminal vascular system is believed to be the primary pathway leading to the pain associated with migraine. The trigeminal vascular system is comprised of nociceptive nerves from the first or the ophthalmic region of the trigeminal ganglia, the major vessel responsible for regulating the cerebral blood flow, and the small vessels in the pain-sensitive covering of the brain known as the meninges. The trigeminal ganglion consists of the pseudo-unipolar nerve cells, primarily A delta and C fibers, that are responsible for transmission of the nociceptive information originating from the meningeal blood vessels to the caudal brainstem or high cervical cord that leads to the headache. While the mechanism by which the migraine attack is initiated is not well understood, the dysfunction in the cerebral nervous system, central nervous system, leading to the release of the inflammatory mediators, is proposed to cause the sensitization and excitation of the trigeminal nerves that promote the neurogenic inflammation and generation of the painful stimuli. The activation of the trigeminal nociceptor mediates the release of neuropeptides such as calcitonin G-related peptide CGRP, substance P, neurokinin A from the primary sensory nerve fibers that are involved in the pain transmission. Now the classification of headache, primary versus secondary. Primary, also known as the idiopathic headache, where the headache itself is a disease, no organic lesion in the background. And in the secondary headache, the headache is only the symptom of the underlying disease. Primary headaches, ICHD 3 beta classification is classified into migraine, tension type headache, trigeminal autonomic cephalgias, where it includes cluster headache, paroxysmal hemicrania continua. Then others includes nummular headache, ice pick headaches, and etc. Now the red flags, as we previously discussed, onset after the age of 55 years, worst headache ever, first severe headache, abnormal neurological examination, fever or unexplained systemic symptoms, signs, pain induced by coughing, bending forward, then pain that disturbs the sleep. Now the pain sensitive structures in the brain are the arteries of the circle of Willis and the few centimeters of their medium sized branches. Meningeal or the dural arteries, large vein, dural venous sinuses, portion of the dura near the blood vessels. Pial vein are not pain sensitives. Now the migraine, the simplified diagnostic criteria, the repeated attacks of headache lasting for more than 4 hours up to 72 hours in a patient with a normal physical examination with no other cause for the headache. And, and at least 2 of the following should be present. That is a unilateral pain, throbbing pain, aggravated by when the headache pain is aggravated by the movements, when the headache is moderate or severe in intensity, plus at least 1 of the following: nausea or vomiting, photophobia and phonophobia. Many patients can have the osmophobia, but that is hypersensitivity to the smell, but it is not included in the criteria. Now the classification of migraine. Migraine is classified as migraine without aura, which is also called as common migraine. Migraine with migraine without aura. Migraine with aura is a classical migraine. The most common aura in the migraine is visual aura. Second most common is somatosensory aura. Then a third type is chronic migraine. Then complications of migraine, which is previously called as the complicated migraine. Then probable migraine. Then episodic syndrome that may be associated with the migraine. Though the headache in the migraine is usually unilateral, but it can be bilateral, occipital, or holocranial too. The headache is not the headache is not side locked always, as we see that in the criteria it is unilateral, but it is not always side locked. It can present in a other way. The most common aura in the migraine is visual aura. Second most common is somatosensory aura, in which the patient complains of paresthesia and tingling in the upper limbs and over the face. Migraine becomes milder and less frequent in the latter life. The incidence of the migraine peak at the puberty. Now the management, there are non-pharmacological management for which we have to identify the triggers and treat it. Then meditation, relaxation techniques, and psychotherapy. Now the pharmacological treatment include two ways, that abortive treatment and preventive treatment. In the abortive therapy, there are specific some agents like triptans, dietons, ergots, and now CGRP antagonists are also there. And non-specific NSAIDs, antiemetics can be used. In the preventive therapy, prophylactically, we can use beta blocker, calcium channel blocker, antidepressant, anticonvulsant, etc. Now the triptans, they are 5-HT1B1D agonist. 5-HT1B agonist, the mechanism is it causes the cranial vasoconstriction, and 1D agonist inhibit the release of neuropeptide substance P and CGRP from the perivascular trigeminal afferents. The mechanism of 5-HT1B1D, these are inhibit the release of CGRP and substance P, inhibit the activation of the trigeminal nerve, and inhibit the vasodilatation in the meninges. There are two types, that slow onset and longer duration of the triptans, and fast onset and shorter duration. Fast onset, shorter with a short duration of action are sumatriptan, rizatriptan, zolmitriptan, almotriptan, elatriptan. Slow onset, longer duration, naratriptan and frovatriptan. So triptans are a reasonable choice for the patient with a moderate to severe disability from the migraine. They have the limit of use 2 to 3 days per week. The reason for which is it has adverse reactions and tachyphylaxis. Patient who fail one triptan often respond to another. So it is not that weak, or if one triptan didn't respond, we can use another triptan. We can try another triptan, but not to use the one triptans within 24 hours of the another, because it will lead to adverse drug reaction. The precautions while using triptans in a patient with ischemic heart diseases or strokes, where the patient has a high risk of coronary artery disease, pregnancy, hemiplegic, or the basilar migraine, we have to be very cautious in using the triptans. In the patient who are taking ergots, the triptans are not used. Migraine with the brainstem aura, we have to be cautious in using the triptans. Then adverse drug reactions are flushing, paresthesia, intolerable taste with the nasal formulation with sumatriptan, then dizziness, drowsiness, and throat tightness. Now the dietons, these new drugs, dietons are just when the serotonergic receptor 5-1, why they come? Because when the serotonergic receptors 5-HT1B1D is activated, it induces the vasoconstriction, neurogenic inflammation, blockage, and a reduction of cephalgic symptoms. But this effect produces a risk of the patient with cardiovascular or the cerebrovascular diseases. So recently, this new molecule called the dietons have been developed. They are selective agonists for the 5-HT1F receptor, with a better tolerability profile compared to the triptans, due to their very low affinity for the and they have very low affinity for the 5-HT1D receptor subtypes. So it is assumed that the activation of the 5-HT1F receptor inhibit the trigeminal impulses, leading to the hyperpolarization of the nerve terminals. So the drug is Lasmiditan. This is FDA approved drug, and it is approved in October 2019. And its efficacy, it is used for the acute migraine therapy with or without aura, without having any vascular effect, vascular side effect. The most common adverse effect which is related to the this drug is dizziness and paresthesia of mild to moderate intensity. Now the second selective agent for the abortive therapy for the migraine is ergots. The mechanism of this is it consists the peripheral and the cranial blood vessels bind to 5-HT, norepinephrine and dopamine and alpha and beta receptors. It is contraindicated in the coronary artery diseases, uncontrolled hypertension, hemiplegic or the basilar migraine. It is also contraindicated in the pregnancy. It is category X drug. It is also contraindicated in the breastfeeding. The adverse drug reactions, it can lead to nausea, vomiting. So pre-treatment with the antiemetics is required. Coronary artery spasm, angina, myocardial infarction, paresthesia, hypertension, tachycardia, and ergotism. The preventive therapy or the prophylactic therapy in the migraine. The indications for prophylactic therapy when the migraine related disability days are more than 3 days per month, then we try prophylactic therapy. Then when the migraine lasts for more than 48 hours, and when the acute treatments are contraindicated, ineffective, or overused. The migraine causing profound disability or the profound aura, in all these conditions, we use the prophylactic therapy. In the prophylactic therapy, the first choice is the beta blockers. The FDA approved for the migraine prevention, the beta blockers are propranolol and timolol. The limited evidence with the nadolol, atenolol, metoprolol. The good choice for the patients with the hypertension, coronary artery disease, tremors, or anxiety. The adverse drug reaction associated with it are depression, exercise intolerance, fatigue, and dizziness. It is avoided in the severe asthma, bradycardia, the patients having the Raynaud's phenomena, overt congestive heart failure. Beta blockers may worsen the aura in some patient without aura, means the patient previously having with migraine without aura can develop after starting beta blocker can develop migraine with aura. So it is we have to be very cautious in using the beta blockers. Then another choice for the preventive therapy is calcium channel blocker. The mechanism is it causes the cranial vasoconstriction, prevention of the platelet aggregation, and alteration in the release and uptake of serotonin. Most widely used is flunarizine and verapamil. Verapamil have some benefits. The flunarizine, though the current concern is in the long-term uses, it can cause Parkinson's. So then another prophylactic therapy for the prevention of migraine is tricyclic antidepressant. None of these are FDA approved. The amitriptyline nor nortriptyline, imipramine can be used. It is avoided in the seizure disorder, cardiac conduction abnormality, and benign prostate hypertrophy. The other antidepressants can be used, that SSRI, fluoxetine, mirtazapine, venlafaxine, and duloxetine. But it is none of them are FDA approved. The anti-epileptics which can be used, the FDA approved anti-epileptics which can be used in the prevention of migraine is divalproex sodium, topiramate. There is limited evidence for gabapentin and zonisamide. Divalproex sodium, it's a common, the divalproex sodium has common dose related adverse effect, like it can cause a weight gain, tremor, nystagmus, and easy bruising. Rare and idiosyncratic reactions can happen with divalproex sodium, hepatotoxicity or granulocytosis, thrombocytopenia, and alopecia. The second choice is a topiramate. The topiramate acts by blocking the NMDA receptors and block the voltage dependent sodium channel, and it enhances the GABA. So adverse drug reaction associated with it is intolerable paresthesia and weight loss. These are the main concern, and cognitive problems, angle closure glaucoma, taste changes, weight loss, suicidal behavior, nephrolithiasis, metabolic acidosis it can lead to. Angle closure glaucoma is one of the dreaded complication, as topiramate leads to ciliary body inflammation, and that will lead to angle closure glaucoma. So we have to watch for the we have to do repeated tonometry, frequently tonometry for the patient who are on topiramate. The gabapentin. Another drug, this is gabapentin. It enhances the GABA activity. It binds to alpha to the delta subunit of the voltage gated calcium channels. It inhibits the high voltage gated calcium current, and all this lead to decreased synaptic transmission. Then botulinum toxin, which we use, and this is FDA approved for the chronic migraine. The mechanism is it blocks the release of the substance P and CGRP and inhibit the peripheral signals to the central nervous system and block the central sensitization. Now the CGRP receptor antagonist in the treatment of migraine. Based on the theories on the migraine pathology, the activation of the trigeminal ganglion nociceptive neurons and the subsequent release of the CGRP, but not the substance P or the neurokinin A, are implicated in the migraine pathology. Now they are focusing mainly on the CGRPs, which is probable pathology for causing the migraine. In the human, the CGRP exists in the two forms that are termed alpha CGRP and beta CGRP, which are derived from the separate genes and differ by 3 amino acids, yet exhibit the similar biochemical function. The alpha CGRPs are in the brain and the pituitary, and beta CGRP in the pancreas and the gut. The 37 amino acid neuropeptide alpha CGRP, which arises from the alternative splicing of the calcitonin gene related CGRP gene, and is the main form expressed in the trigeminal ganglion neurons, and the most essential, which is most essential for the migraine pathology. In contrast, the beta CGRP, which is encoded by the different gene that is highly homologous to the calcitonin CGRP genes, is primarily expressed in the enteric nerves and in the pituitary gland, and its role, if any, in the migraine is still not known. The CGRP is widely distributed in the central nervous system and the peripheral nervous system, where it is predominantly expressed in the C and the A delta nerve fibers that transmits the nociceptive signals to the central nervous system. The CGRP released from the fibers that are associated with the meningeal vessel is thought to mediate the vasodilatation and the mast cell degradation. So this is the physiology. The activation of the platelets and the mast cell degranulation will lead to the release of the pro-inflammatory agents that mediate the sensitization of the trigeminal nociceptors and may be involved in sustaining the painful phase of the migraine. Following the trigeminal nerve activation, the CGRP would be released from the fiber, projecting to the trigeminal nucleus caudalis that facilitates the excitation of the second order neuron and the glial cells involved in the initiation and the maintenance of the persistent pain. That CGRP is a autologous, it causes the process pathophysiology which leads to migraine. Now the drugs which are CGRP antagonist, the first potent and the selective non-peptide antagonist of the human CGRP receptor, which is first used, is olcegepant. The olcegepant function as a CGRP receptor antagonist, which by directly competing for the binding site of the endogenous ligand CGRP, and therefore it inhibits the physiological and the cellular effect of the CGRP. This drug has got the first direct evidence to support the use of the non-peptide CGRP receptor antagonist as an abortive therapy for the migraine. The lack of these CGRP antagonists lack the cardiovascular side effects such as the changes in the blood pressure or the heart rate. A major limitation for the usefulness of this hydrophilic compound was that the fact that it has to be administered by the IV injection. So it is the major limitation, but it lacks cardiovascular side effects. Second is telkechepant. It is It has a more useful delivery method. It is given by the oral route. It is highly selective and was shown to be effective generally in the patient with the generally in the patient for the acute treatment of the migraine. Used for treating moderate to severe migraine attacks with a primary endpoint of the pain relief at 2 hours. Effectiveness of tolkien to relieve the pain and the other migraine symptoms at the 2 hours, as well as providing sustained pain relief for up to 24 hours. The adverse drug reaction associated with telcigipant is nausea, dizziness, somnolence, and hepatotoxicity. That's why the trial has been stopped, and the olsigipan and telkigipan was discouraged because of the unfavorable safety profile and the route of administration, the only intravenous, and the hepatotoxicity is a main concern with both of these two drugs. And now the new CGRP antagonists with our gipants for the abortive therapy are the urogipant, rimegipant, atogipant, zevegipant, and vazegipant. These amongst these, the atogipant is approved in September 2021, 8 to 9 months ago, and it is by the oral route, and it is the newest. Zevegipant and vazegipant, these are administered intranasally, and they are under trials. And vazegipant can come in a coming days, which is proposed for approval now. The result for the atogipant, which is just newly launched, is well tolerated, and drug-related serious adverse drug reactions were absent. The CGRP monoclonal antibodies. The benefit of using it has a long half-life, and it is well accepted by the patient, with one administration every 4 or 12 weeks apart. So all the monoclonal antibodies acting on the CGRP have been shown to modify and improve quality of life, headache-related disability, with a good efficacy and tolerability. For the preventive therapy, monoclonal antibodies used are the framinezumab, galcanezumab, irenumab, and iftinezumab. So iftinezumab, it is used by the intravenous route, all are used by the subcutaneous route. Iftinezumab is approved in the February 2020. So 1.5 years ago, the iftinezumab is approved. Thank you.
So, good, Atish. It was very exhaustive coverage. And when it's a very huge topic, really
Yes,
cover.
Yes, sir.
I think invite some questions. Sir is there? I think sir is not there. Yeah, Lal Kaka, sir.
I think it was an extremely well covered topic. Very well done. I liked your slides, your typing and all, really good. Excellent.
Thank you, sir.
Fantastic. I think you covered so much.
Yes.
In this time.
The only thing is that the ending was a little abrupt. We would have liked to listen to this RNU no? Because that is a new thing that these pharma companies are
Yes,
promoting.
Yes, sir.
I think you forgot to cover Arunumab. Sir, how many patients you have used Arunumab? You have started using it?
Who, me?
Yes, sir.
No.
I have also not used.
I have also not used it. I was hoping that, one of you, Ashok or someone has used it so that we can also start.
I was basically following the Osler's rule. Don't be the first to start and don't be the last to start.
But sir, if you see the worldwide usage, it is really picked up, and reasonably safe drug. I mean, whatever we hear in as a real life data from others, the only the limiting side effect probably is actually constipation. You know, some patients had to be taken off the drug because of the severe constipation. And the problem is that because it has a very long half-life, if you give just once a day, there is no way to, kind of that effect of constipation tends to continue for a month.
Yeah, interesting.
That is one of the drawbacks. Plus, it's a unknown thing. There are, the CGRP is used. It's used as a normal system in so many body parts. So many systems use CGRP. We still don't know what effect these antibodies will have in the other systems.
Correct.
Are there some hidden side effects which the companies don't tell us? And those are the real limiting factors in using these new antibodies.
Right. Maybe Rakesh, since you have been guiding this this presentation, if you wanted to make any other comments, first you make them, then we'll open it for.
Now, sir,
are there any other points you want to make?
The comment which I wanted to make, one of them is that the usual preventive and the abortive treatments, what is the role of this greater occipital nerve block and the use of cephaly? Because some of them are they are totally devoid of any kind of side effects, and they are reasonably effective. But somehow we feel that we are not using them enough. I think GON blocks are used elsewhere very, very commonly, especially for migraine in actually pregnancies. And the blocks tend to work quite well. So that I wanted to just open for the discussion. And the CGRP is there. We have not yet used it. But I think it will play a big role in the treatment, because that 50% responder rates to our usual therapies is quite poor. I think not many patients do well on this prophylactic treatment, and they tend to keep on suffering. So probably CGRPs will have a big role to play.
What do you think, Jimmy? What percentage of your migraine patients improve, you think, with your standard? Whatever our old style therapy.
I think that I'm not very. I think patients are not very satisfied, and I'm not very satisfied. It's very rare for a patient to say, "Okay, look, thank you so much. I met you 6 months ago, and there is no more headache. Thank you very much." I can't recollect any patient saying like this. Some of them talk about a little improvement. Some don't improve at all. Some keep harassing. Till you tell them, "Okay, we'll have to admit for LP," then they may disappear.
Yes. and even the headache disappears.
Exactly.
Exactly.
It's also interesting how our goalposts keep changing. Like in migraine, like you said, a lot of us in our minds have accepted that they will sort of be partly better and they will come and go, and you will reassure them that there isn't any tumor, and they go on and you go on. So the goalpost is partial benefit, alleviating the anxiety and things like that. And if you take a corollary of myasthenia gravis, and you see what rituximab has done to some patients, you are amazed. You are amazed that the disease is killed and finished.
Yes, sir. Yes.
In a small proportion of them, but wherever it does, it finishes them. So the goalpost is changed to finishing the disease. Then otherwise, what were we doing in myasthenia? 10 milligram steroids increase, this. So I think, are we looking at a changing goalpost in the treatment of migraine, that they must be cured with these new medicines? Or is is it still evolving?
I think, sir, it is still symptomatic only. I mean, CGRPs ultimately it just targets a pain inciting mechanism. So that is why used both as a abortive, also as a preventive therapy. But as per the claims, it seems to be almost moderately to very nicely effective. So, but probably because it's a unknown drug, we are still not. At least I am not very comfortable, using once a month, giving one shot and then waiting for a month to see how it acts. Somehow it doesn't. We feel very comfortable using Erunumab.
But Rakesh, I
Yes,
I recollect one patient who had come to me. I had not started this drug. He came with someone else having given him this drug. I don't know who it was, but he saw me about 3 to 4 months after. So he had taken 3 or 4 injections, and he reported to me that the headaches are hardly there.
yes, sir. That is what even the company claims and the world data claims that the headaches can, in I think 10 to 15%, the headaches may just vanish also.
Yeah. So I think the real gold standard is to really see if there are really any side effects worth. If there are no particular, I mean, constipation, yes, it's a good thought, But otherwise, it might be a useful drug to try.
Yes, sir. Absolutely.
Ashok, your thoughts? To me, it seems to be such a common condition. How and monoclonal antibody?
I get the impression that Indian neurologists are not using greater auricular blocks enough. So I don't know, because if you see the data on file, for most people go in for CGRP after the failure of conventional drug therapy, after the failure of either greater auricular nerve blocks or Botox in the head, and only then they go to CGRP. We seem to be jumping the gun. There could be possibly a proportion of patients would could benefit by intervention. I keep on telling myself I should start doing it. But then I never got around to doing it. How many of us are doing it? You or Jimmy or Rakesh?
No, I think Girish was doing it, and Girish thinks that the success rates are good. But I have 2 comments to make. One is that the CGRP has a driver behind it, so it will go in overdrive. The block doesn't have any driver, so the block will
superbly put.
And secondly, I think these methodologies of treatment are so varied that common sense says that there is something still lacking.
Quite right. But this greater auricular nerve block, who does it? Have you had anyone doing it? Ashok, Satish?
Girish was doing it, and then he was impressed by it. So in JJ, I think in 2015 or so, we wanted to do a project, but I have no idea whether it caught on or what happened. Maybe one of the residents will know whether there is a project going on at the moment.
But sir, the block doesn't need any specialized. It's just a local. You have to just localize a greater occipital nerve and inject lidocaine there, and that is all. It's not a very major procedure, or it can be simply done as
an office procedure to be done in the
office procedure.
Yeah.
But Rakesh, that must be only for those who have occipital headaches, no?
Even for migraine.
I
mean, the usual migraine, hemicranial migraine, data says it is very, very effective.
Achha. Later, occipital nerve.
Yeah. It is best, as you rightly said, for that occipital neuralgic pains. But like, sir, in migraine during pregnancy, when we can't use much of the drugs, gone can be given, and it says.
No, what I meant was that, not occipital neuralgia, but, migraines The typical migraine pain can also be occipital, largely. So if those type of occipital migraine pains might improve, but would it improve, when there is a hammering in the temple region, or the frontal region? Would that help?
Okay, correct, sir. But I think probably that also helps.
Okay, okay.
Somebody should do a proper study, and JJ is the place. So I think Rakesh can take it up. A proper study of where to do it.
We have given for one patient, sir.
Can you please, who is this? It only says 817691 here. Who is it?
Atish.
I think the Atish.
Okay. Yeah. Bolo Atish.
So we have tried in one patient actually on the OPD basis, just 1 month back, but he is not in follow. So we'll come later on. We'll
make a good study out of it. Yes. These things need to be evaluated by somebody who is unbiased.
Yes.
So have a good ombudsman on the project.
Yes.
Sir, how about Cephali? Have you used Cephali, sir? There are like Dr. Chonkar is there at Mulund, and she keeps in her OPD and puts it in the patient, and she says it works really well, and of course it is FDA approved.
What is it? Which one?
It's an external device, Cephali.
Cephali. It is a trigeminal efferent stimulator. Just put it on your forehead, and patient sits in the OPD.
Yeah.
Oh
yeah. Cephali is commercially available, but
available, yes.
But then you come to whose law is it? When you have a hammer in your hand, everything looks like a nail.
Yes.
Very true.
So I think you actually need somebody who is not doing any of this to design a good project for you, and then somebody can execute it.
Yes.
You can have a methodology that first give the first order drugs and then use Cephali or whatever you want to do.
Yeah.
But if you start believing in it, then there are people who believe in stem cells working. So I think there is much more involved in this than.
I think the first prerequisite is that there should not be any driving license.
Yes.
Yeah. Ashok.
One take-home point for all the soon to be becoming practicing neurologists in this meeting. People have talked so much about management of migraine. But there is one elephant in the room that no one talks about in managing migraine, is how you communicate to the patients, how you explain to them that this is a terrible headache. I agree with you, this is impending death and permanent disability. That feeling is there in you. But I assure you that is not the sequence of events. I assure you, as you age, the problem is going to slowly get burnt out. This is more like a reactivity problems to so many environmental and personal issues that you're facing. It is related to your lack of food, lack of sleep, lack of discipline, either religious fasting or what have you. On Mumbai, what I call Mumbai fasting. Your husband tells that he's going to come for dinner at 8 p.m. and he lands up at 10:30 at night in the traffic. So whatever it is, that the link, the way you explain to the patient, the way you talk to patient, that extra 3 minutes or extra 5 minutes you take with the patient is, according to me, I'm absolutely convinced has a bearing on the final result of the management of your patient. Take it or leave it. You may not agree with me, but this is what I strongly feel.
No,
I don't know what others.
No, I think you make a very important point that finally, what are our expectations? What does the patient want? What do we think can be achieved?
Yeah.
All those are the cornerstones of a successful
long-term management of migraine.
Yeah. I mean, just that you said, when you said that there are patients, I mean, most patients, at least as the books say, as the age advances, they become better. But there is a small subgroup where it doesn't get better.
It doesn't get better.
Is there any information on that?
Agreed. Oh, they're tough. They're tough to manage.
I mean, they read and they come and say, look, it's not going away.
Yeah.
I've become old enough, it's not going away, but I don't know.
Sir, I have seen that one of the triggering factor in our patient is poor sleeping patterns. The sleeping patterns have become so abnormal and erratic that people don't feel abnormal when they tell you that I am sleeping at 2 o'clock in the night. Sir, I am sleeping for 7 hours. If you ask them 3 baje so ke 9 baje utha, I told if you're sleeping like this, your migraine is never going to go away. Me using anything. I mean, sir, that has changed. I think lifestyle patterns have become so erratic.
Changes every, It's
that
getting,
I think migraine keeps coming back all the time.
I think it's a maladjustment between whatever his migraine triggers are and what his life is. And they are different for everyone. Like there are also chaps who wake up early in the morning and get a headache.
Yes.
So I think it's the balance between him and his environment.
Yes.
Right. So do we move on to the next one, or are there anyone wants to make any other points before we move on?
Sir, Azad, just want to ask about these detans. Anyone has used those?
Not yet, I think, available as a lasmetidan.
Oh, okay.
And so one of the problem with lasme is that you can't drive for at least 8 hours after taking the injection, unlike the other abortive treatment. It causes a lot of drowsiness.
Yeah, our guys take valproate and then sit on the wheel.
Yeah.
For whatever the reason.
Yes.
Yeah. No, I have not tried the triptans, and I must say I'm not too enamored by them also. They work in some and not in all. I think it's that, again, that aphorism that an old doctor has one medicine for 20 diseases and a young doctor has 20 medicines for one disease. I'm experiencing that now. I prefer to stay within the norm of the drugs that I am comfortable with. Jimmy, same thing happening to you? Or you are happy about new drugs? Ashok?
I missed that. Well, sorry, Satish, what were you saying?
No, I was saying that an old doctor has 20 for 20 diseases has one medicine, and a young doctor has 20 medicines for one disease.
Yes.
I think I have migrated to that one tablet thing. Have you?
Yes, I think so. Certainly. I think so. Yeah.
So for all the people who are doing DM neurology, 20 medicines for every disease, till you graduate to that level.
Till the exam is over.
Till the exam.
Then I think you should graduate to one in, drugs.
Slowly.
Yeah.
Right. So we move on to the next one, cranial neuralgias. Dr. Chandrasekhar, guided by Dr. Lal Kaka. Chandrasekhar, you ready?
Yes, sir.
Yeah. Shoot.
Good morning, sir. Today I am going to cover cranial neuralgia. Although most headache disorders have been attributed to pathophysiology within the brain, the irritation of the individual nerves in the peripheral nervous system can contribute to head and facial pain as well. So neuralgia is a brief paroxysmal, often triggered lancinating pain within a specific nerve dermatome, sometimes described as a sharp stabbing or electric shock-like pain. Whereas neuropathy is a sensory deficit within the nerve distribution, and there will be a persistent pain with neuropathic features, often described as burning, tingling, or pricking type with false sense of swelling. So both neuralgia and painful neuropathy have been described in trigeminal, glossopharyngeal, and facial, as well as in terminal branches of the upper cervical nerves, such as occipital and greater auricular nerves. So trigeminal neuralgia. The trigeminal neuralgia, there will be a recurrent paroxysms of unilateral facial pain in the distributions of one or more divisions of the trigeminal nerve with no radiation behind and fulfilling criteria of B and C. The pain has all the following characters, which is the severe intensity and lasting from few seconds to 2 minutes. It's a very electric shock like pain, shooting, stabbing, sharpening quality, usually precipitated by triggers within the affected trigeminal distribution, not better accounted by another international classification head disorder diagnosis. In classical trigeminal neuralgia, there will be a unilateral paroxysmal facial pain in the distribution of trigeminal nerve, along with the signs of neurovascular compression on MRI imaging, and including nerve atrophy and displacement. Whereas in secondary trigeminal neuralgia, the trigeminal neuralgia due to multiple sclerosis plaque or local mass such as pontocerebellar tumor that will compressing the nerve. Idiopathic trigeminal neuralgia is called when there is no etiology, when the etiology is unknown, with normal appearing MRI and normal electrophysiological tests. 99% of the patients with trigeminal neuralgia will have a triggers. The usual triggers will be chewing, eating, and talking, and shaving and brushing teeth, and cold will on the face also can cause trigeminal neuralgia. Most of the patients with trigeminal neuralgia are pain-free, but some patients will have continuous background pain. Then the term is called as classical trigeminal neuralgia with concomitant continuous pain. The right trigeminal nerve is usually more affected than the left one, and the maxillary mandibular divisions are more affected than the ophthalmic division of the trigeminal nerve. So usually mild autonomic symptoms can be expected in trigeminal neuralgia, but if autonomic symptoms are pronounced, then we should suspect short-lasting unilateral neurologiform headache with autonomic symptoms, or short-lasting unilateral neurological headaches with autonomic symptoms with conjunctival injection and tearing. And most of the patients with trigeminal neuralgia will have normal sensation. If pronounced sensory deficit will be seen, then we should consider for the alternative diagnosis of painful trigeminal neuropathy. For example, if the patient notices numbness in the mental nerve distribution, or the syndrome is called numb chin syndrome, it is a red flag for neoplastic etiology. The pathophysiology of classical trigeminal neuralgia is the vascular compression. Usually the trigeminal nerve is compressed by the superior cerebral artery or anterior inferior cerebral artery, rarely by trigeminal vein and superior petrosal vein. The root entry zone is called a trigeminal nerve root, where it enters the pons is most vulnerable to the injury. The neurovascular compression may lead to focal demyelination with subsequent trigeminal hyperexcitability, leading to generation of the ectopic impulses from the demyelinated axons. These ectopic impulses that originated from the demyelinated axons will excite the neuron, surrounding neurons such as pain-carrying fibers. Injury-induced changes that creates ectopic pacemaker with self-sustained firing. During a burst of firing, the calcium-activated potassium channel will open, that will cause hyperpolarization. If hyperpolarization is significant enough, that will prevent firing and leads to the refractory period in trigeminal neuralgia. But up to 11% of the patients with trigeminal neuralgia have family history. They have a strong genetic predisposition to demyelination or nerve hyperexcitability. When a patient young age presents with both sides of trigeminal neuralgia or in combination with other neuralgia, we should consider familial trigeminal neuralgia. The trigeminal neuralgia is average onset is older than 50 years. If a secondary idiopathic terminal neuralgia usually present at younger age. Trigeminal neuralgia is usually sporadic. There is a positive family history present in 11% of the patients, usually associated with glossopharyngeal neuralgia, hemifacial spasm, and earlier onset and bilateral location. So familial trigeminal neuralgia is also has been associated with Charcot-Marie-Tooth syndrome, where abnormal myelin might have contributed to the vulnerable to nerve compression. And also in some of the patients will have genetic predisposition to the peripheral nerve hyperexcitability. And some patients will have multiple genetic variants in sodium channels, potassium channels, chloride and calcium channels on exome sequencing. So secondary trigeminal neuralgia. The red flags were with bilateral trigeminal neuralgia, younger onset, pronounced sensory changes. The causes will be multiple sclerosis or tumor at the cerebellopontal angle. The rare causes will be AV malformation, epidermoid cyst, aneurysm, small infarcts in the pons and medulla, and the bony compression due to osteoma or osteogenesis imperfecta. Usually the MRI of the brain with contrast, the thin resolution cuts through the posterior fossa, you identify the trigeminal neuralgia. Here is the MRI showing left superior cerebellar artery that will causing atrophy of the left trigeminal nerve. The medical treatment is mainly focused on the stabilization of the membrane that likes to suppress the hyperexcitability of the nerve. Usually carbamazepine in the doses of 200 mg per day to 12,000 mg per day, or oxacarbamazepine 300 mg per day to 1800 mg per day. Usual side effects will be hyponatremia, drowsiness, and liver damage should be monitored. Lamotrigine, gabapentin, and onabotulinum toxin injections are also effective in trigeminal neuralgia. The baclofen, topiramate, valproate, levetiracetam, and can be also tried. Some patients will usually present with acute exacerbation of trigeminal neuralgia that cannot, they can't even take food with severe pain. In that case, they have to be admitted, and IV phosphonate and possibly IV lidocaine should be given at the dose of 5 mg per kg body weight over 1 hour. The acute pain relief with peripheral blocks with bupivacaine or with lidocaine. The ultrasound guided trigeminal nerve blocks by the pterygopalatine fossa is also useful. When medical treatment fails or intolerable side effects with medical treatment, then we should consider for microvascular decompression. This is the first line. If the patient has the evidence of neurovascular compression on imaging, and there will be no contraindication to the surgery. And the 68 to 88% of the patients will respond at 1 to 2 years post-operatively, and 64% of the patient will still pain-free 10 years after the surgery. So usually the retromastoid incision will be given and posterior fossa will be explored. Here is the vessel is compressing the trigeminal nerve. Either the Teflon sheet that is placed between the nerve and vessel relieve the compression. The risk of pain recurrence is more common in female sex, and symptoms lasting longer than 8 years. The venous compression rather than arterial compression causing the trigeminal neuralgia, or presence of arachnoiditis, lack of immediate post-operative pain relief, and the presence of persistent pain between the attacks will cause recurrent pain. The recurrence of trigeminal neuralgia is also possible after even microvascular decompression, and we need to re-explore. In that case, the compression with the synthetic material used in the decompression, or Teflon granuloma, or formation of arachnoiditis, arachnoid adhesions will need re-exploration. The neuroablative procedures in trigeminal neuralgia patients without neurovascular compression on imaging will go for neuroablative procedures such as stereotactic radiosurgery. In this, they will target the beam of radiation with gamma knife and cyber cave to the part of trigeminal nerve. Some favor the targeting the route of entry zone close to the brainstem. Some other favors just proximal to the trigeminal ganglion or ganglion itself. The multiple studies have shown both are equally effective. The pain relief after radiosurgery will start from 2 weeks to 2 months. And the decreased sensation may start after 6 to 38 months of the treatment. The percutaneous lesioning of the trigeminal nerve, it can be caused by chemical destruction with glycerol or mechanical destruction with balloon compression. The initial pain relief with percutaneous procedure is very high. More than 90% of the patients will get pain relief, but the relief falls to the 53% to 69% by 3 years. And also partial sensory rhizotomy or internal neural. Surgical section of the sensory root of trigeminal nerve, the clinical response will be seen in 70 to 88% of the patients. Internal neurals consist of dissecting sensory and motor roots of the trigeminal nerve into 5 to 10 fasciculi from the root entry zone. Improvement was reported in 77% of the patient after 1 year and 72% of patient 5 years after post-operative. The painful trigeminal neuropathy. It should be considered when the patient presents with numbness in one or more branches of the trigeminal nerve associated with persistent neuropathic pain. Usually local trauma following dental procedure, salivary gland biopsy, facelift, and the neuropathy after neuroablative procedures will also cause painful trigeminal neuropathy. And also post-herpetic neuralgia. Acute herpes zoster can cause painful trigeminal neuropathy. It will cause pain in the distributions of one or more branches of the trigeminal branch with herpetic vessels in the same distribution as pain. If the pain lasts more than 3 months, it's called as post-herpetic neuralgia. The first line treatment include tricyclic antidepressants and anti-epileptic drugs or topical medicine. The numb chin syndrome is in the absence of any dental procedure, numbness without neuropathic pain, isolated chin is a worrisome. The presenting symptom of a orofacial or systemic malignancy. Most common malignancy associated with numb chin syndrome is breast cancer, followed by lymphoma, prostate cancer, and leukemia. In numb chin syndrome, when suspected, the facial MRI with gadolinium, with special attention to the inferior alveolar canal, should be done. And if malignancy is strongly suspected, CT chest, abdomen and pelvis, PET scan, and CSF for malignant cells should be considered. Another important neuralgia is glossopharyngeal neuralgia. In glossopharyngeal neuralgia, there will be a unilateral paroxysmal electric shock-like pain over the posterior tongue, pharynx, tonsillar fossa, deep in the ear, beneath the angle of jaw. It is usually provoked by swallowing, yawning, and coughing, even sometimes talking also. Like trigeminal neuralgia, it attacks also last for 2 seconds to 2 minutes, and can co-occur with other neuralgia. 2% of the patients with glossopharyngeal neuralgia usually complain of symptoms of syncope, bradycardia, hypertension, even cardiac arrest. It is due to the spillover of the glossopharyngeal impulses to the dorsal motor nucleus of vagus during that time. The compression of the glossopharyngeal vagal complex is usually caused by posterior inferior cerebral artery, but less commonly by anterior inferior cerebral artery or vertebral artery. The secondary causes of glossopharyngeal neuralgia is demyelinating lesions, skull basin tumors, laryngo-oropharyngeal tumors, infections like parapharyngeal abscess, or any carotid sheath trauma, or elongated calcified styloid can cause glossopharyngeal neuralgia. The treatment of glossopharyngeal neuralgia is usually carbamazepine, oxocarbamazepine, and a topical anesthetic over the pharynx and transpiller is also useful. Extraoral glossopharyngeal nerve blocks gives temporary pain relief. And if there is a neurovascular compression by the posterior inferior cerebral artery or any artery visible on imaging, usually microvascular decompression preferred. And stereotactic radiosurgery, radiofrequency ablation, balloon compression can also be tried. The nervus intermedius neuralgia. The nervus intermedius is a branch of the facial nerve that carries the parasympathetic nerve fibers from lacrimal nasopalatal glands, as well as sensory information from the tongue and conch of the ear. It is also called as geniculate neuralgia. In this, the patient usually complains of stabbing pain in the ear, triggered by the even cold wind or using a cotton swab. The pain is usually accompanied by the disorder of lacrimation and salivation and taste. Usually these develop in the setting of classical Bell's palsy or after a Ramsay-Hunt syndrome, that is herpes zoster affecting the ear and facial nerve. If the pain persistent longer than 3 months, it's called as post-herpetic neuralgia of nervus. The treatment of nervus intermedius neuralgia is carbamazepine and other anti-epileptic drugs. The both microvascular decompression and sectioning of the nervus intermedius can be also tried. The occipital neuralgia. The occipital neuralgia is, this is the lesser occipital nerve, which takes origin from the C2, C3 spinal nerves, wind around the sternocleidomastoid and supplies over the lateral part of the skull. And this is the greater occipital nerve, which take origin from the dorsal ramus of the C3 spine and extends from the posterior posterior part of the skull base towards the vertex. And third occipital nerve is a take origin from the C3 dorsal ramus and extends from the posterior part of the skull base to the middle part of the neck and lower part of the occipital skull. If there is a shooting like pain, stabbing like pain from extending from the posterior skull base to the vertex, usually greater occipital neuralgia is suspected. When pain extends from the posterior skull base to over the ear to the lateral part of the skull, such as temple region, we should suspect lesser occipital neuralgia. So most common cause will be irritation of the upper cervical nerve roots by blood vessels or Chiari malformations, rarely secondary to the lesions in the upper cervical cord, cavernous malformation or demyelination lesion. Sometimes occipital nerve schwannoma can also cause. MR of the brain with cervical pain in patients with new or unexplained occipital neuralgia suspected can be done. The treatment will be in occipital neuralgia is anti-epileptic drugs, tricyclic antidepressant, nerve blocks for flares. Those who are not responding to medical therapy or repeated blocks can benefit from pulse radio frequency treatment, neurolysis, or onabotulism taxane. In some patients, severe pain refractory to medication, even nerve blocks, alternative diagnosis such as atlantoaxial or upper zygotophyseal joints should also be considered. Thank you.
Very nice, Chandrasekhar. Very well done.
Crisp.
Very crisp and clear. So maybe if you can turn your slides off, we can request Dr. Lal Kaka, your guide, to make his comments, and then we open it for discussion.
No, I think you mentioned it quite well. I think Chandrasekhar, you've done a good job. I think you have covered the things very nicely and in good time. I think actually Dr. Azad Irani has also worked on this. And, can I please request Azad to make some comments on this chapter?
Yes, sir. Hi. So, yeah, very nicely presented by Dr. Chandrasekhar. So most of the points are covered, just a few extra points which we thought that would be good for discussion. 2 points mainly. One is that many of the trigeminal neuralgia patients who have been well controlled and suddenly have a poor control despite being on good medicines will turn out to have high blood pressure. And on searching, there is actually a lot of literature on this as well. So it's probably the vessel that is pumping faster and actually hitting the nerve. And the second thing is many of the patients who have temporomandibular joint pains in association often have this confusion whether the pain, because in an elderly age, TM joint arthritis is actually very, very common. So how many patients have that dual pathology, and that's why I don't completely respond. Rest of it, I think is covered very well.
Yeah. Very important point. Again, blood pressure coming up. Ashok.
I'm terribly disturbed at my failure of diagnosing and managing numb chin syndrome or a painful chin syndrome. Once or twice, I have seen it in cancer patients. So that means it becomes easy. But the difficulty arises when there is no association of malignancy in the history. Patients are well, there's no complaints of medicine, there's no weight loss. And then they start coming with this. And then you keep asking questions, you keep worrying about it. And I never really, Chandrasekhar has made a point that could be, is it paraneoplastic or neoplastic? Is it the lesion in the inferior alveolar nerve or the facial nerve where you just, I have not scanned every patient. I have not done a facial nerve MRI in every patient. The face MRI, what Chandrasekhar mentioned, that you need to face MRI to eliminate the inferior alveolar canal. I've not done that. But very odd. Does anyone else have any disturbing, upsetting experience with this?
Yes, sir. Sir, I'll just say one of the doctor's mother here, around 60-year-old, and she complained of pain around the mental area only on one side, and the pain was quite there, and she also had some numbness when I saw her. She had typical numb chin syndrome only on the right side, only V3 division. We did a simple scan which turned out to be actually normal. 10 days later, she had similar complaints on the left V3 division. Again, that whole area became numb. And this was my first experience of seeing that, we have only read in the books, numb chin syndrome is a red flag, and this patient turned out to be a diffuse lymphoma. And this was my first experience with the numb chin. Numb chin is really, really a kind of red flag. If you see numbness there, even patient may look very, very benign initially, but actually they are harboring very bad diseases.
I think I have one comment to make here. When we are saying numb chin syndrome, we are talking of a trigeminal neuropathy and not trigeminal neuralgia. That we have to be very clear with.
Yes, yes.
The moment there is a sensory loss in the area that is affected, then you are talking of different structural diseases.
True.
And trigeminal nerve is a nerve that is particularly susceptible to neoplastic infiltrations, because neoplastic infiltrations go to the larger nerves. So trigeminal is one of the largest. So it's commonly affected by the neoplastic processes. So I think one for the postgraduate students, neuralgia from neuropathy. Neuropathy, then you think of Sjogren syndrome, other autoimmune conditions, medicines like the medicine for Kala Azar typically affects used to affect the trigeminal nerve. So neuropathy versus neuralgia, number one. What's the comment of people on trigeminal neuralgia in V3 division? Does it also have these connotations or no? I am not sure.
V3 division.
V3 neuralgia without neuropathy, I think is like any other V1 or V2 neuralgia.
I think it's just like other V1, V2 neuralgia. The classical one, starting from, the origin of the V3 and going right down to the chin, with all the exacerbating features of, with washing and with brushing teeth, they, I think, would be of the same connotation as the other type of trigeminal neuralgia.
Yeah. One other point I want to make, I've been very intrigued by the fact for a long time now that patients who have tremendous pain in the day and are uncomfortable and can't eat, the moment they sleep, the pain is gone. If you ask them, how many times do you wake up in the night? Very few will say that they wake up. So what's the relation of sleep with this disease has been a curiosity to me. So we actually kept data of some, I forget how many, we published it somewhere, 50, 60 patients. And when a newly diagnosed trigeminal neuralgia came, they did wake up in the night a few times. But as the condition, as the control started coming with medication, night became all right.
They were sleeping with the medication?
Medication was throughout the day. And some drug-naive patients spontaneously mentioned that once they sleep, they are okay. So there is something about sleep and trigeminal neuralgia. And amongst those who were waking up, it was usually the V2 neuralgia. So whether the nose touches the bed. So I'm intrigued by this. Does anyone have any comments to make on this?
Sir, another intriguing thing which I have always seen in patients of trigeminal and sometimes can be used to, I think, diagnostic value is prior dental procedure. Yeah. I don't know what happens, something is done during dental thing and they land up into typical classical trigeminal sometimes, almost 90% will have some history of dental thing done in past on the same side. I don't know what is the relation.
No, it is also possible that the pain is interpreted as a dental pain.
Exactly.
Therefore, they go to the dentist, and because they have come to the dentist looks at everything.
Yeah, exactly.
And something is always found. When you look, something is always found. I mean, that's the rule. You keep looking till you find something.
Rakesh, usually, you know, they come with this pain, and these dental people do 2-3 procedures, you know, and which doesn't help them and makes it worse.
Yeah.
Sometimes makes it worse. Yes.
Yes.
But this numb chin, actually, I completely point well taken. You know, it's a trigeminal neuropathy. But I mean, why should it affect only the chin? Why not the entire distribution of the V3? And besides, you know, I have actually never tried to image the alveolar nerve. You know, I hope I have not missed. You know, I mean, at the most, I asked for an MRI brain with a focus on the trigeminal nerve, but I've never tried to image the, you know, this dental, this alveolar nerve.
But Jimmy, with whatever work we've done with paraneoplastic cranial nerves and and immunological cranial nerves, in this patient who had the alveolar problem, I would suspect that he would also have something in the ganglion, trigeminal ganglion. Rakesh can tell us, was the ganglion okay, Rakesh?
So ganglion was okay. Ultimately, it was found that the mental foramen, there was a deposit there.
But there was nothing proximally.
Nothing proximally, sir. MRI was done couple of times. Only when the symptoms started to appear on the other side, a detailed cut of that mental foramen was taken. He had a deposit there, and then PET showed everything.
Wow. Very interesting.
You know, in lymphomas, if you do imaging well enough, you can see diffusion restriction in the nerves.
Okay.
And our today's 3D machines are capable of showing you that.
I see.
One case that I keep showing in multiple places, the trigeminal nerve was thickened and it showed diffusion restriction. And the patient had lymphoma. So nerves are thickened, it is infiltration, sometimes sarcoidosis. And if it shows diffusion restriction, it is a lymphoma.
Right. Interesting.
Yeah, there is a question from Santosh.
Yes.
Once if you have given IV phenytoin in acute pain, would you continue oral phenytoin? If so, how long? Because it is not a routine drug for trigeminal neuralgia. Jimmy?
I must say that I have never used IV phosphenytoin ever for an acute exacerbation of the trigeminal neuralgia, you know. And I have a feeling that, you know, I mean, if it is to work, you know, I mean, if he waits for 4 or 5 hours, you know, after giving an oral dose, I think it should respond. Anyone else has tried IV phosphenytoin?
No.
I would not bother about giving long-term oral phenytoin.
Yeah.
They're given IV phenytoin only because there's no IV carbamazepine available. That's only reason why I think of it.
So there are some.
Yes.
Sorry.
Azad?
No, sir, you continue.
No, please tell me.
No, so there are some patients, we've had 2 in the last 1 year, who are in so much pain that they can't open their mouth to take the oral tablet. That's when we have given the IV phenytoin.
That's a good thought.
Yes.
Yes. But then maybe we could give the liquid dilantin and all, no? Like we give in children.
Okay. No, they just can't open their mouth.
Yeah.
Also, like Ashok pointed out in the previous discussion, communication with them is very important, because a lot of them, once the pain goes away, they stop the medicines.
Right.
And then they come back with such pain that whatever you do, you find it difficult to control.
Yeah.
That's I think the longer I look at it, the more I feel it's a communication failure on our part. That what is to be done after 4 weeks, we never tell.
Correct. Yeah, point taken. Guilty as charged.
Right. So, do we go to the next one now?
Sir, one small thing.
Yes, please.
Which patient to refer for microvascular decompression. Now, when we ask for MRI with the CIS sequences, often the report says a very plus minus neurovascular conflict and patient has intense pain. Now, I'm just worried that if I send to a neurosurgical guy, is it possible that he goes in and doesn't find any compression? I'm just worried because they're level 5 surgery, and if I am not convinced before going in for surgery that there is a significant neurovascular conflict, I mean, if you ask them, they will say even if you're not seeing in the routine MRIs, there is always a compression. So I'm a little bit, doubtful when to send them.
Right. Now, what I think the comment will be that it is true that surgeons may sometimes find an issue that is not so clearly defined on the MRI study. Also, surgeons will tell you and patients will tell you that even in some of them in whom there was no neurovascular conflict, the procedure changed something favorably. These patients also there. So I have been keeping it on the level of the pain, and the disturbance produced by the pain is that person's life. If medicines are not working, then it is worth a chance. But it's completely case-based as far as I am concerned. What does Jimmy and Ashok, what do you think?
About? Sorry.
When to send a patient to surgery?
Yeah.
Maybe what I can also...
Increasing pain despite of regular medication in adequate dose.
Yes, it's worth exploring.
Very often I give polytherapy also, just to avoid surgery. Obviously, if there is a deficit or if there is imaging abnormality, that goes off much before I go to full dose. But increasing distressing pain is a good indicator. When the graph of the pain is going higher and higher, despite regular medication, I worry.
But I would go in for radiofrequency thermocoagulation. Not
any day.
Yeah, not the surgical decompression.
Now this is a tricky question. Radio frequency, they don't talk about it, but they also have a certain degree of failures of procedure.
Yeah.
In microvascular decompression, I would say, provided there is no lethal complication, which is 1 to 3% in good hands, in the best of hands, it is curative. They don't come and meet you. They at the most send you a Diwali card. They don't waste the time come to meet you. They don't even waste the time coming to meet you.
Also, the for the radio frequency, you can't do it in V1.
Exactly.
You can't do. It's not easy for males who want to shave.
So, right. But I mean,
and also the condition has natural remissions in
Yeah.
spite of loops.
Yes.
No, because to go in and do a major posterior fossa surgery, I mean, there would be risks involved.
But the field is moving towards early surgery, just like early surgery for Parkinson's disease, early surgery for everything.
Right.
I think we at the moment seem to be believing a lot in our abilities to help them that way.
Right.
Yeah, I think Varsha along with me wrote one review paper on trigeminal neuralgia's medical management in Neurology India. So I will tell her to put it up on the group.
Oh, very nice.
There, this question is also dealt with: whom to send for surgery and when to send for surgery. So shall we go to the next one? The cluster and the other tax. Swati Sharma and Azad.
Good morning, sir.
Good morning. Swati, you are at Jaslok?
Yes, sir.
Okay.
I'll start screen sharing. So, sorry, 1 second. So good morning, everyone. The topic of discussion now is cluster headache and trigeminal autonomic cephalalgias. Am I audible?
Yep.
Yes. Okay. So cluster headache and trigeminal autonomic cephalalgias are a distinct set of headache diseases typified by shorter lasting attacks of unilateral intense pain in the trigeminal distribution with ipsilateral cranial autonomic symptoms. So this spectrum includes cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attack syndromes, and hemicrania continua. Believed to result from dysfunction in the trigeminal and cranial autonomic systems and their connections, modulated by the hypothalamus. In contrast to migraine, the pain of these syndromes is by definition almost universally unilateral, prominently located in the V1 distribution, shorter lasting with the exception of hemicrania continua, and more intense. Overshadowing nausea, photophobia, or phonophobia, the predominant associated features are autonomic in nature, such as ptosis, meiosis, lacrimation, periorbital edema, rhinorrhea, facial sweating, flushing, and oral fullness. Other features, including migrainous symptoms and neck pain, can be present but are not listed within the diagnostic criteria. Now, what is the pathophysiology of trigeminal autonomic cephalalgias? This is a diagram given in the continuum, which says that the pathogenesis involves at least 3 systems, which includes the pain system, the trigeminal nerve, the trigeminal-vascular complex, and the general pain system called the pain neuromatrix. It also involves the cranial autonomic system, which includes the superior salivatory nucleus and the sphenopalatine ganglion and the hypothalamus. So we will talk about each of these very briefly. So the trigeminal nerve, the pain of cluster headache and TACs is usually felt in the dermatome of V1, and it implicates that the trigeminal nerve is as involved as least in the pain component. Then we have the trigeminal vascular system, like the trigeminal neurons which innervate the cerebral blood vessels, and they release calcitonin gene-related peptide, substance P, and vasoactive intestinal peptide. So CGRP is a part of the trigeminal system and is a target system for triptans. And VIP, vasoactive intestinal peptide, is released in the superior salivatory nucleus and is a target system for oxygen. Similarly, melatonin is released in the hypothalamus, which is a target for verapamil and lithium. So that helps us in understanding, it makes us know why it is important to know the pathophysiology, because it is a target system for the various treatments involved. Then we have the trigeminal autonomic reflex. It is a physiological reflex by which a painful stimulus in the trigeminal region results in reflex activity in the ipsilateral facial parasympathetic system, which is the cause of lacrimation, conjunctival injection, rhinorrhea, and facial swelling. The afferent limb of the trigeminal sensory neurons and efferent limb of the parasympathetic neurons traveling with the facial nerve from the superior salivatory nucleus via the sphenopalatine ganglion is involved in this system. Then we have the hypothalamus. Now, there is a marked circadian periodicity observed in cluster headache patients, which suggests that neuronal populations which have circadian and fluctuations must play a role in the pathophysiology of TACs. The human biological clock is the suprachiasmatic nuclei located in the anterior hypothalamus, and there are compounds known as orexin A and B, which are neuropeptides produced exclusively by a small area of neurons in the posterior and lateral hypothalamus. So they are involved in the regulation of wakefulness and food intake. And a polymorphism in the orexin receptor gene has been demonstrated to increase the risk of cluster headache in some genetic studies, which has been supported by functional imaging studies as well. Then there are some cortical factors. Cortical processing of pain is incompletely understood, and there is no central area for the processing of pain. But most studies have implicated the insula, anterior cingulate cortex, and regions of the frontal cortex in pain processing. So we will now briefly discuss about the various headaches. First, coming to cluster headache. it is the location is unilateral, frontal, temporal, or periorbital. The attack duration is for minutes to hours. It always has autonomic features. Sometimes migrainous features may be present, and the exacerbants are alcohol and sleep. So this mnemonic known as SEER defines cluster headache: side-locked, excruciating, agitating, and regularly recurring pain. So these are the diagnostic criteria for cluster headache. At least 5 attacks fulfilling the following criteria: severe, unilateral, orbital, supraorbital, or temporal pain lasting for at least 15 to 180 minutes, which with, as we mentioned, injection, edema, forehead and sweating, meiosis and ptosis. And this is important, a sense of restlessness or agitation, because in patients of like the patients of migraine, they tend to stay still. But any patient who moves restlessly on the bed, is extremely restless, is more a candidate for cluster headache than migraine. So a sense of restlessness or agitation is a very important diagnostic criterion, and it occurs with a frequency between 1 every other day and 8 per day, and not accounted for by other diagnoses. So it is very important to rule out secondary causes or mimics of trigeminal autonomic cephalalgias before we diagnose. So the vascular mimics include cervical arterial dissection, carotid artery thrombosis, carotid cavernous sinus fistula, venous sinus thrombosis, subclavian steal syndrome, or lateral medullary infarction. Then we have non-vascular mimics, which include glaucoma, sinusitis, trigeminal nerve root compression, cavernous sinus metastasis, meningioma, pituitary tumor, clival epidermoid, and IIH. So these are some evidence. These are the evidence-based guidelines for the treatment of cluster headache. So in any acute attack, subcutaneous sumatriptan, zolmitriptan nasal spray, or 100% oxygen helps. The preventive treatment for level A use is suboccipital steroid injection. Then sumatriptan nasal spray and oral zolmitriptan have also been used. This is not really used in practice. So these are the medications for cluster headache. Sorry. Verapamil, lithium, topiramate, melatonin, gabapentin, or sodium valproate. So we should know all the common side effects and choose the medication accordingly. Then we have already spoken about CGRP monoclonal antibodies in migraine. In cluster headache, a randomized controlled trial of the monoclonal antibody galcanezumab given subcutaneously at a dose of 300 milligram once a month showed a small but significant reduction in headache frequency. Then fremanezumab has also been trialed. However, the trial was discontinued as it was unlikely to meet its primary endpoint. Then we have certain non-invasive, we have these transitional treatments like greater occipital nerve injection, and we have invasive neurostimulation like occipital nerve stimulation, sphenopalatine ganglion stimulation, and deep brain stimulation. So coming to paroxysmal hemicrania, what are the criteria? It is a unilateral frontal, temporal, or periorbital headache, lasts for minutes, always has autonomic features with some migrainous features. The exacerbant here is neck turning and not alcohol. And importantly, this paroxysmal hemicrania responds exquisitely to indomethacin and associated with circadian periodicity, affecting women more than men. So these are the diagnostic criteria: at least 20 attacks fulfilling the unilateral headache with cranial autonomic symptoms, restlessness, agitation, with a frequency of greater than 5 per day, and prevented absolutely by therapeutic doses of indomethacin. So the pathophysiology is similar to that of cluster headache with an important distinction. The functional imaging studies indicate hypothalamic dysfunction contralateral to the expression of pain and autonomic features. So it is indomethacin responsive, starting dose of 25 milligrams thrice a day for at least 3 days before escalating to 50 milligrams thrice a day for 3 to 10 days before considering any further escalation. However, when indomethacin is ineffective, we can also use celecoxib, verapamil, topiramate, gabapentin, botulinum toxin, acetazolamide, or subcutaneous or intranasal triptans. But the evidence of these therapies is very weak. Coming to SUNCT and SUNA, short-lasting unilateral neuralgiform headache attack syndromes. They are unilateral in the V1 distribution, last for seconds to minutes. Autonomic features are always present. Migrainous features are rarely present. And the exacerbants are cutaneous, thermal, or mechanical stimulation. So SUNCT has conjunctival tearing and SUNA has cranial autonomic symptoms. Again, the diagnostic criteria, at least 20 attacks with unilateral head pain lasting for 1 to 600 seconds, occurring as single stabs, series of stabs, or in a sawtooth pattern with autonomic symptoms, frequency of at least once a day. So this is a diagram demonstrating the pattern of headache seen in SUNCT or SUNA. So it can either be single stabs lasting for 1 to 600 seconds, repetitive stabs occurring over a course of 1 to 20 minutes, a plateau pattern over a course of 5 to 300 seconds. Then we have the sawtooth pattern, in which the pain occurs between 5 seconds to 200 minutes with these on and off 1 to 600 second exacerbations. And we have plateau plus exacerbations, which lasts for total 30 minutes with these stabbing episodes lasting for 1 to 600 seconds. So these are the various patterns seen in the SUNCT and SUNA spectrum. So the pathophysiology is the same as we discussed, with variable hypothalamic activation. However, in addition, and similar to trigeminal neuralgia, vascular loop compression of the trigeminal nerve has been identified in some cases. No refractory period is seen in contrast to trigeminal neuralgia, and alcohol has no effect on this entity. So this is a flowchart which demonstrates how to manage a case of SUNCT or SUNA. So it depends on the attack load. If there is a low attack load, which means infrequent attacks lasting for very small duration, we can give lamotrigine 100 to 400 milligrams per day. If it is a moderate attack load, which means frequent attack and the pain lasts for longer duration in a day with moderate disability, we can give lamotrigine and add transitional therapies, which includes oral steroids or occipital nerve block or Botox injection. And if it is a status, like more than 30 attacks per hour, we give IV lidocaine for 5 to 7 days. And if there is a poor response, we give oral steroids or occipital nerve injection block or lidocaine. However, if there is a poor response to all these therapies, we label it as refractory SUNCT or SUNA syndrome. And if there is evidence of neurovascular contact, we go for MVD. If there is no evidence of neurovascular contact, occipital nerve stimulation. And still, if it is refractory, we consider hypothalamic DBS. Now coming to the last entity, which is hemicrania continua. It is a unilateral baseline pain with superimposed attacks of more intense pain accompanied by autonomic features. A foreign body sensation in the ipsilateral eye and stabbing pains are very common. Migraine features are not usual, which can make it difficult to distinguish from chronic migraine. So these are the diagnostic criteria. Unilateral headache present for greater than 3 months with exacerbations of moderate or greater intensity, with autonomic symptoms as mentioned, sense of restlessness or agitation, and response to therapeutic doses of indomethacin. So this is a diagram demonstrating the differential diagnosis. So A is the typical hemicrania continua kind of pain, a continuous mild to moderate background pain with superimposed severe exacerbations. However, if we ignore the background pain and only consider the exacerbation symptoms, then the differential diagnosis can be migraine, cluster headache, paroxysmal hemicrania, or SUNCT, or even trigeminal neuralgia. And if we only consider the background pain into consideration, then secondary headache, chronic migraine, tension type headache, and new daily persistent headache can also be the differential diagnosis of paroxysmal hemicrania. So a PET study has demonstrated that activation of contralateral posterior hypothalamus, midbrain, rostral pons, and pontomedullary junction is also present in paroxysmal hemicrania. And as I mentioned, the orexinergic system is the main circuit to regulate the hypothalamus. So that has also been demonstrated to play a role in paroxysmal hemicrania. as mentioned, indomethacin is the drug of choice, and topiramate is the best alternative to indomethacin. COX-2 inhibitors, gabapentin, and melatonin can be other alternatives. And these are the various studies published for paroxysmal hemicrania with peripheral nerve block, radiofrequency ablation, or vagus nerve stimulation, and even Botox, which have shown good response. And these are the various studies that have been published over the course of 10 years. So this is a summary of all the TACs that we discussed. Cluster headache with attack duration of 15 to 180 minutes, paroxysmal hemicrania 2 to 30 minutes, Sankt and Suna 1 to 600 seconds, hemicrania continua, continuous pain with superimposed attack lasting for minutes to days. Then attack frequency in cluster headache is every other day to 8 per day. Paroxysmal hemicrania is 1 to 40 per day. Sankt and Suna dozens to hundreds per day, and hemicrania continua up to dozens per day superimposed on continuous headache. Then acute treatment for cluster headache is oxygen, sumatriptan, non-invasive VNS. For paroxysmal hemicrania, attacks are too short to go for acute treatment, and preventive treatment includes, for cluster headache, includes steroids, verapamil, lithium, galcanezumab, and VNS. For paroxysmal hemicrania and hemicrania continua, they are indomethacin responsive headaches, and Sankt and Suna responds to lamotrigine, topiramate, gabapentin, and in some patients, indomethacin. Most importantly, we should medicate, but also listen and empathize with patients. There is a paper published in Headache 2021 about the lesser known themes identified from a mixed method analysis of cluster headache survey, which tells us about the psychological impact that cluster headache has on patients, that you will eat shoe polish if you think it would help, because that's the extent of suffering that they bear. So we should empathize with them as well, apart from medicating. Thank you.
Excellent, Dr. Swati. Very, very clear. Azad's comments?
She's covered everything. It was really well spoken. Very nice. Very nice, Swati.
Thank you, sir.
Can I make one, tell you very briefly about a case that I recently saw, which has really intrigued me. In a minute, can I tell you about a case, or it's
Of
out
course.
of scope? Out of scope.
No, of
Yes, sir.
course.
Yes, sir.
This is a boy of about 27. He's son of a doctor. And he first got what looks like left-sided brachial neuritis. He was given steroids. He became better. About a month later, he developed headaches on the left side, which were periodic, coming every day at a fixed time. Left eye was becoming small and watery and becoming red. And the face generally was sweating more on that side. And he was diagnosed as cluster headache. Again, he received steroids for the cluster headache. Again, he became better. After a little gap, he developed a new pain which fulfilled the criteria of trigeminal neuralgia. And then he was on all kinds of medications for trigeminal neuralgia, which only partly helped her. Partly helped meaning the trigeminal neuralgia pain became periodic. That it will come from 7 a.m. till 10 a.m. But the characters were that of trigeminal neuralgia. And lastly, he developed hemifacial spasm on the side of the where the trigeminal neuralgia was. So all this happened over a span of about 4 months. Imaging picked up nothing. CSF picked up nothing. First brachial neuritis, then cluster headache, then trigeminal neuralgia, and then hemifacial spasm. So I've got no clue what is happening, but I'm treating symptomatically. And I'm one of the many, many neurologists who is treating him. Ashok.
Any COVID-19?
He had COVID about a year before.
No,
about 1 year before the brachial neuritis. But what happened immediately preceding the neuritis was a trip to for a trek.
I'm seeing some bizarre combination with COVID. Facial improves, then ptosis improves. I mean, there's no sense. I mean, it doesn't make sense to me. And MRIs, LPs, same like this. CBC,
Normal.
ANAs, everything negative. Some bizarre, illogical.
And Jimmy, any thoughts?
I think two
Or
things.
Rakesh? Yeah.
Two things, two things. One is he a medical student?
No. You would wonder whether he is making it up.
That's one. And number two is,
But his father is a doctor and
Ah.
he's very concerned. So that possibility is there in the background. But the hemifacial spasm is genuine. The red eye is genuine.
But the hemifacial spasm is sort of because of the neuralgia?
Well, I mean, like the tic douloureux.
Yeah. The second thing is, such rare things and, these nerves being affected, have been tested for Lyme disease?
He's been tested. He has been tested. He's seen so many neurologists that every investigation has been done.
But we should, have we done the full whole body PET scan?
That is what I have suggested for a lymphoma.
Must do it.
Because
Just to see for lymphoma.
Too many things are happening. I have suggested that to him.
Yeah, some sort of infiltrative thing.
Amazing case.
And sarcoid.
Sarcoid has been studied, negative.
Right.
Chest CT is negative and ACE is negative.
Right.
Let's see what evolves.
Yeah, I think whole body PET must be done.
And things are getting better also. The brachial neuritis improved, the cluster improved.
Yeah.
So it's not relentless and things being added.
Have we ever given steroids? Have we ever given?
Always.
2 times for brachial neuritis and then for cluster.
And then did it help at that time?
It helped. It helped, and both those events that improved stayed improved.
But that again can be, in lymphoma we can get a beneficial effect of steroid.
He's going to get his PET CT.
Correct.
The other point, this man has been going through the country seeing various neurologists. And he made a point that very few people are able to give time to his son.
Yeah.
I think so valuable.
We'll ask Dr. Swati. She's the most well-read on cluster headache.
Yeah.
There is something called secondary cluster headaches. And one of the rules of cluster headache management is that if you diagnose the trigeminal autonomic cephalgia, and on your treatment, the patient does not report an immediate improvement, you have to image the patient, which is not the law for migraine. If migraine, it is not absolutely compulsory, but I think all of us do when migraine doesn't get well. A cluster headache is a law because secondary cluster headaches, pituitary lesions, trigeminal lesions are well described in the so-called cluster headache syndrome or so-called TAC syndrome. Is there something like a secondary TAC associated with infection or collagen vascular of a collagen disorder?
Good question.
I'm not aware of this. I know about tumors and space occupation. I don't know about vasculitis associated with secondary TAC.
Swati, anything in the reading?
She's most well read. That's why we are asked.
Sir, I didn't come across vasculitis in any of the literature that I read, but I'll read more and find out if
because
there is any.
If you're forced to give a diagnosis for Satish's patient with a gun on your head, you would say this is some form of vasculitis involving 1, 2, 3, all kinds of places in the nervous system. The only thing that, like Dr. Kathak said, the only thing connecting all this thing is the blood vessel. Nothing else connects the.
His standard ANA blot and ACE and ANCA and all that has been done repeatedly.
That's it. You're in trouble. You're in trouble.
Any other comments on this presentation? I mean, these are rare headaches, but unusual.
Sir, the cluster headaches, so we see time and again, not very common, of course. I have seen around 2-3 cluster headache patients. In all of them, I had difficulty in preventing the headaches during the clusters. I mean, when they say I am getting at the fixed time in the middle of night, what they often ask, doctor, what should I take at night time to prevent that?
Oxygen.
Indomethacin.
Now,
Oxygen.
Oxygen, sir, actually during the headache,
It
the
works.
hospital, they take it.
No, there are these portable oxygen cylinders now.
Yes.
COVID has made that provision for the society. There are 2 or 3 patients at the moment who keep these cylinders
you
at
can
home.
hire them actually. You can hire them.
Yeah, you can hire them. Small cylinders are now available.
Yeah.
And it
But
works
sir,
well for them.
but can we do something like maybe nocturnal ergot or a nocturnal
Indomethacin works.
indomethacin
works well.
I
Okay.
give them one tablet every night before go to bed, so they don't wake me
Which
up.
one? Which one, sir?
Indomethacin. one tablet.
Indomethacin. Huh? I've been using actually ergot, ergot for this indication, like nocturnal dose of 2 milligram, 4 milligrams, tends to work well along with combination of steroids.
SOS steroids.
No, sir. I mean, for maybe 6-7 days during their clusters, tapering course of steroid, which tends to work well with some patients. Actually.
That's good to know. That's one other option. Yeah. How much do you give?
Like say 30 milligram at night time, and next day 20 milligram tends to work well for whatever few patients I have seen for clusters. And if they get headaches in the night time, then of course the standard abortive therapy.
Pratik, you need to mute yourself. Pratik? Thank you. Right. Right. So I wish Ravi was here. I had invited him, but he's away to United States. Because one other curious cluster headache patient I'm seeing, where whatever I use, he gets acclimatized to it, and then it increases his headache. And this has happened with 4 agents. It starts helping him first, then it sort of stops helping him, and then the tablet induces the cluster. Any experience like this? And this has happened with 4 medications. Well, someday I'll bring that case history.
Yes.
Yeah. Right. So we go to the next one now. That's Azad, no? Yeah. Clinic-based,
Yes, sir.
very important one. Clinic-based procedures for headaches. Azad is going to do it himself. Azad.
Yes. So, in fact, this is just what we were talking when the second lecture on migraine therapies was concluding. So, clinic-based procedures for headache. Headache disorders are common and disabling. Local procedures are known to be effective. And these 4 procedures are what we are going to discuss today. They include the Botox injections, the peripheral nerve blocks, mainly the greater occipital nerve blocks, trigger point injections, and sphenopalatine ganglion blocks. These are the 4 procedures for headache and facial pains. So, introduction. When do we, if ever, think of resorting to these procedures? When the headaches are completely resistant to all the known pharmacotherapies, patients may not be able to tolerate pharmacotherapies due to side effects or due to contraindications we can't give them, especially elderly with polypharmacy or in the pregnancy group. A few headaches may only be responsive to local therapies despite trying all medicines. And obviously, when people are not doing the active lifestyle management, which is very important. So before we start the talk, just a few questions everyone can answer in their mind. Some of us may not even have heard of these. So have you ever heard of any of these 4 procedures? Have you seen any of these 4 procedures being done? Have you ever used it on any of your patients? Any of your colleagues having used it, do you know? And how often, even in a case discussion, when we have discussions on difficult headache cases, has anybody actually ended up discussing why not try a block? We go to medicines, and have we really even discussed this? So honestly, my answer to most of these questions was no. So a lot of new things to learn for me here, maybe for some others as well. So what are the 4 talks? Like I said, these 4. Okay, let's start with Botox. So onabotulinum toxin A it has been approved for preventive therapy for chronic migraine and for some other things, other headache disorders as well, which we will discuss. So it is as a preventive therapy, whereas all the other 3 procedures are for the acute treatment of a short-term prevention. So Botox. Botox therapy has been approved for episodic and chronic migraine as a preventive or prophylactic therapy. What is the mechanism of action? So it is given on multiple sites around the face and scalp. We will see that. It internalizes with the neurons at this snare protein complex, and accordingly gives an inhibitory effect on many of the neurotransmitters like the CGRP, etc. It also prevents the C-type meningeal nociceptors that crosses the skull and suture lines, and hence has some local effects. What is more important is that from just local injections, we have seen that it can actually have effect on the central receptors. Why? Because patients' auras have gone off for a long time, and it is not just the effect of a local injection that is seen with placebo injections or with things like acupuncture. So what were the approval studies? Now, many RCTs were being done, but the most important of them were Preempt 1 and Preempt 2 for Botox. These were the pivotal trials done on a pretty large number of patients. Preempt 1, 341 patients, and it showed 2 important things, that the number of days and the number of headaches significantly reduced as compared to placebo. Hence, Preempt 2 was a continuation of study where the primary, secondary endpoints were changed, and this further strengthened this belief. And since then, since the Preempt trials had taken place, Botox has been an approved therapy. So totally almost 1,400 patients in Europe and United States for this Preempt trial, and it had shown significant reduction in the total headache days per month and the headache events. The average here, so the average number of headaches per patient was 18 plus minus 3, and that reduced by 8.5. So more than 50, almost a 50% benefit. So those were studies which told us that it helps initially in the preventive aspect. Studies were taken up whether Botox can continue to be effective for even 2 years. Yes, it may have to be repeated every 3 to 4 months, but even at 2 years, most patients still had significant benefit after a Botox injection. So that was the COMPEL study. Just some thinking points like we spoke, the benefit from placebos were also substantial. So 6.5 headache days were reduced from the 18. That itself is substantial even for the placebo, which generates consideration that the treatment effect will not just be from the action of Botox, but from even simple neuromodulation and mechanical factors such as needling, very much like acupuncture. Of course, Botox compared to the placebo was even more beneficial. Let us see how the procedure is. So the patient is in a sitting or a supine position. Reconstitution of the Botox should be done in preservative-free normal saline, never mix it with anesthetics. 155 units is what the general dose is. And the injections are repeated every 3 months, like for any other Botox indication. These are the areas where it is given. The corrugator, the procerus, the frontalis, occipitalis, and the paraspinal and temporalis. It is on both sides, always on both sides. So what are the possible side effects of Botox injection? Neck pain used to be the most commonest due to neck extensor weakness. However, recently the guidelines have changed and it's given much higher up in the paraspinal muscles, and this has reduced the neck extensor weakness. Similarly, brow ptosis was also a side effect, because of which the injection is now being given on the lateral aspect of the mid-pupillary line instead of the medial. Again, a recent change. And last is drug wear off. So even though that COMPEL study had shown that the Botox effects is as beneficial even when repeated at 2 years, clinically many people say that there is a drug wear off which occurs after around 6 to 8 doses. Whether that is due to antibodies to the Botox or no, nobody has ever proven. but even like Botox being used in other conditions, there is a drug wear-off which is seen and follow-up. It should be avoided for patients with a neuromuscular junction disorder or a patient with a skull defect, because they say the Botox can diffuse through and enter the brain. Cost obviously remains a concern. This was a recent study completed in 2018 end, published in 2019, which showed that even compared to topiramate, Botox was more beneficial in terms of lesser side effects and in a significantly higher number of patients having more than 50% reduction in headache days. Considering all this, Botox would be ideal to give it in a patient who is not tolerating medicines or who cannot receive medicines, especially these three groups: pregnancy, breastfeeding, and elderly. However, for pregnancy, the safety is not well documented, and hence most doctors do not give it, especially if they know the patient is pregnant. However, theoretically, Botox has a high molecular weight and should not cross the placenta. And many pregnant ladies who received Botox because they never knew that they were pregnant never had any increased rates of fetal side effects. As for breastfeeding women and for elderly, it is considered very safe and is used. So finally, before we go to the next one, what are the places where Botox can be used? Migraine, where it is approved, has been tried in cluster headaches, new daily persistent headaches, chronic post-traumatic headache, pneumolar headache, which is a coin-shaped headache, not very well explained in literature, trigeminal neuralgias, and bruxism. Out of these, it is approved only for migraine and for bruxism. The others, there is not yet enough data for them to approve it. And it has also been used in some case reports for status migrainosus, when even steroids, IV steroids have failed. Next, we go to peripheral nerve blocks. Generally, bupivacaine or another anesthetic agent is used. So peripheral nerve blocks for headache consists of injections of local anesthetics, at times along with steroids, in accessible nerve branches on the head, including the greater occipital nerve mainly, and also sometimes the lesser occipital nerve, auriculotemporal, supratrochlear, and supraorbital. It is used as an acute or a short-term prevention therapy. Not yet approved, but there is significant data that has been amassed by multiple studies, so much so that for cluster headaches, it has a level A recommendation now. And since cluster headaches, like we have just discussed, do not have so many efficient therapies, this certainly should be kept in mind more often. Peripheral nerve blocks are often performed as just a component of treatment. The rest of the preventive therapy and lifestyle therapy must continue. So it is generally added to the medications. Again, a couple of studies. So more than 50% reduction in headache days with the greater occipital nerve blockade for chronic migraine. Again, the first, this is migraine where it's still not approved, but significant data. More than 50% reduction as compared to placebo. An ultrasound guided technique showed even greater efficacy. That is when we properly localize the greater occipital nerve. These were the short-term effects seen of greater occipital nerve blocks on chronic migraine. Again, showed that there was a significant reduction in the number of headache days, and also the pain thresholds in general improved for these patients. Again, showing that a local therapy has central desensitization effects. Again, for chronic migraine, a study on a shorter group, 44 patients only. So that was for migraine, where it has been seen to be successful but not approved. For cluster headache, 2 randomized clinical trials demonstrated that steroid injection. So yes, we have to use steroid alone or steroid with the local anesthetic, ipsilateral to the side of pain, superior to placebo for short-term prevention. It also provides an additional option to oral steroids. And yes, it has received level A recommendation by the latest American Headache Society. These are the studies which showed almost an 80% improvement in the cluster headache symptoms at a time between 4 to 6 months. So it even persisted. This is the level A recommendation by the American Headache Society. So let us now discuss the procedure, how a peripheral nerve block is to be done. What drug is used? It's an anesthetic. What dose is to be used? The greater occipital nerve injections generally need a larger volume, 2 to 4 ml. The rest are less than 1 ml each. Any other addition? Yes, a steroid for clusters is recommended. Sites, like we discussed, mainly it is the greater occipital nerve. However, we have some more sites where it has been seen that addition to greater occipital nerve, it can have some better effects also in selected cases. Addition of blocks, yeah, okay. Duration of benefit from 1 to 4 weeks. So that is the problem. They need to be repeated more frequently. Any drug interactions? None really. It can be a simple outpatient clinical procedure where USG guidance may benefit even more. What about any side effects or contraindications? Yes. Side effects, so the local dermatomal numbness because of the anesthetic, which is expected, which may be more than the duration of the normal anesthetic effect. Sorry. And the most important precaution to be aware, again, like we said in Botox, is to make sure that the patient has not had any craniotomy, craniectomy, etc., or any pacemaker, any place where the agent can diffuse through. In fact, 2 cases of anesthesia diffusing via these subcutaneous planes into the brain and resulting in reversible coma are also on literature. So that is the main contraindication. These are some of the other safety considerations which we have to keep in mind for the greater occipital nerve injections. And for the next one, which I'm going to discuss, that is trigger point injections. They will mainly be, so if there's somebody has an anesthesia allergy, we can try only steroids. During pregnancy, we avoid using bupivacaine. If patients have vasovagal attacks, which anybody can get to any injection which is put in them, we allow a longer time, supine time. Open skull defect or craniectomy is a contraindication. If a patient is using antithrombotics or even anticoagulants, no need to deprive the patient of this. We just need to compress for a longer time. That's about it. Cosmetic reasons, yes, this can be a small area of alopecia around the area injected. In that case, steroid doses should be lower. And the last point is actually for the next the trigger point injections. So again, where are finally greater occipital nerve blocks used? Migraine, very often used but not approved. Cluster headache, not approved but enough evidence. Occipital neuralgias, very, very effective with least side effects. Cervicogenic headaches, of course, this whether there is a condition called cervicogenic headache has always been debated. And lastly, again in status migrainosus. What about pregnancy, breastfeeding, and elderly, like we discussed for Botox? So they can be an excellent treatment option for pregnant patients. Only thing, do not use bupivacaine. And again, for elderly, excellent option. Sorry. Next, let us go to trigger point injections. So many patients with headaches, especially the tension type headaches or the migraine, will say there is a particular point where if they press, their pain increases. So basically, we inject and target those points. So trigger point injections involve the administration of anesthetics into myofascial structures that may serve as mechanical sites that evoke or perpetuate an underlying headache disorder, most commonly migraine and tension type headache. Again, it has to be used with continuation of other oral prophylactic agents. Sometimes trigger point injections, that is injections into these myofascial structures, are combined with nerve blocks as well. How to identify these trigger points? They are identified purely on physical examination as a taut band of muscle and defined as sites of pain in the muscle or fascia that when irritated or compressed, evoke the same pain that the patient is getting. That is the index pain. Trigger points are found more often in patients with TTH and migraine. Mechanism, they say the persistent activation leads to local ischemia, muscle contraction, and inflammatory substances. And by injecting an anesthetic here, that cycle will be cut off. So the common sites mainly are the trapezius, the sternocleidomastoid, the temporalis, occipitalis, frontalis, semispinalis, semicapitis, and masseter and levator scapulae. Commonly areas which patients complain of in tension type headache, or what we often term as a sorry, I'm missing that name, chronic fatigue syndrome and stuff like that. So these are again some studies. Studies on smaller fibromyalgia. Yes, sir. Yeah. Fibromyalgia. Correct. Sorry. Yeah. So these are some studies again which show significant benefit, but they are on very small number of patients, mainly done on patients with tension type headache or migraine, where injecting into the trigger points have shown very statistically significant improvement in pain severity, number of pain episodes, and on all the quality of life scales as well. Similar studies, again, short number of patients. Procedure details, like we discussed for the other topics. No USG guidance is needed here because it is basically based on clinical examination. However, we have to be careful when injecting the trapezius because some patients may have anatomical abnormalities where they have a high-lying pleura, and that's where a pneumothorax can be a danger. So maybe for the trapezius, it may be important. Otherwise, anesthetics are generally used alone. Systemic steroids of myotoxicity makes people scared of using them into the muscle. There is no clear evidence that Botox in these areas can help, like the trapezius, etc. But there are papers which say that in addition to the 155 units on the face, an additional 40 units, if a patient has trigger points, can be injected onto those trigger points, and that may have a greater benefit. Again, the volume injected is very small, but it has to be repeated frequently, maybe monthly, because they don't last long. Safety concerns are the same like we discussed for the peripheral nerve blocks. That is these. The only last one was the extra one, where it will be better to use an ultrasound or an EMG guidance to avoid hitting the pleura. That brings us to the last one, sphenopalatine ganglion blocks. Now, theoretically, out of all, people have tried to target this the most because they feel this is actually the seat for all the pathophysiologic mechanisms for almost all facial pains, migraines, and all primary headache disorders. But the success, unfortunately, has been the least. So the sphenopalatine ganglion is a large parasympathetic ganglion lying in the pterygopalatine or the sphenopalatine fossa that also contains the trigeminal sympathetic projections. It is a key peripheral structure involved in expression of the autonomic symptoms and plays an important role in the trigemino-autonomic reflex, which we know is very important in most headache disorders, especially the trigeminal autonomic cephalgias. What have been the methods to target it? So mainly people have targeted an intranasal medication delivery, either a self-medication with a cotton tip, with a cotton swab, or with a catheter. Now there are percutaneous blocks as well, because it seems it is more easily approachable and more definitively approachable if a percutaneous block is used. Intranasal blocks like catheters, and other newer methods like neurostimulation, chemical neurolysis, and ablation procedures are coming up. This is the place where the sphenopalatine ganglion is, and in an intranasal procedure, this is a catheter, or we use a cotton tip and locally swirl it. Studies in trigeminal neuralgia. So no major studies, most of them have been small case reports, but one of the case report had 25 patients, and the strongest evidence managed was it still managed to give only a recommendation B. At the clinic, the sphenopalatine ganglion block is generally one of the two. Like I said, the older technique was just to dip a cotton swab in a liquid or a viscous anesthetic like lignocaine or bupivacaine and insert it into the nasal passage deep enough and keep it resting there for a few minutes. The second method is the recently developed nasal catheters, which is attached to a syringe like I had shown in the previous diagram. And the self-administration cotton tip can even be done at home. Caution and side effects. The good thing is it does not generally need any imaging, especially when done intranasally. The percutaneous blocks are different. They should be avoided if a person has any nasal surgeries done in the past, because we don't know where it will diffuse and cause any central nervous system side effects. Common side effects will include a loss of taste or a poor taste due to the anesthesia effect, which will last for a few days or a few weeks. Similar paresthesia in the nose and the throat, again, because of which is mainly in the first few hours, and hence a patient may be asked not to swallow for the first 6 hours or so. At times, it can drop the blood pressure because of the parasympathetic action. And if there is local trauma, there can be epistaxis, etc. So overall, theoretically, it is a great target, but has never been proven to be of great benefit. But still, small publications show it has much promise. So where is the grade B recommendation, if at all, for? Grade B recommendation is for cluster headaches, trigeminal neuralgias affecting the V2 division, because that's which comes on to this ganglion. Migraine, reducing the pain post nasal pack removal. So again, it's basically a local anesthetic effect, and it seems it's very much in vogue for patients who need high levels of analgesics after a functional endoscopic sinus surgery. It's being used very commonly by ENT surgeons there. This is a rather funny slide where it has been tried for almost 20 more disorders, including essential hypertension. And this has been going on since lots of years, but never any confirmatory evidence. There is this book, The Miracle Block, which made one of the octogenarian ENT very famous. And also it is being used for other conditions, and including, like I said, almost 24 conditions. So finally, to summarize this talk, after pivotal clinical trials, Botox has become established preventive therapy for chronic migraine and seems to be better tolerated than many of the oral pharmacological treatments. It may also be useful for other headache disorders. Next, the peripheral nerve blocks, especially the greater occipital nerve blocks, have amassed enough evidence from randomized trial from acute and short-term preventive therapy for migraine and cluster headache. Next, the trigger point injections also show efficacy in migraine and tension type headaches. And the sphenopalatine ganglion blocks are very easy and have great potential. Theoretically, the training needs to be strengthened, both theoretical and practical. Thank you.
Very nice talk, Azad, about the newer things. Shall we open it for questions and comments? Jimmy, you want to make a comment, Ashok?
I think it's an extremely good talk, Azad. Excellent. And these are things that we don't use. So, these give us further, options in our management.
Azad, it was wonderful talk as usual.
Thank you, sir. Thank you.
I think you have opened another field for neurologists to take up. People go for DSAs and stroke. I think this is also one of the field which I think we can venture into, and with a very good value for the patients. Nobody have been using it, these blocks, which seems to have such a good effect without any significant side effects.
Jimmy,
wonderful.
Rakesh.
Yes, sir.
I'm not able to tell you a name. Can we have a 2-hour workshop in a BNA meeting on non-Botox procedures for cranial pains?
Yeah, it was a fantastic idea. Great idea.
You are a senior member of the executive committee of the BNA.
Yes, sir.
So please.
I'll propose it, sir.
Don't propose it. You have to first these guys are good in BNA. The current batch is very good. I promise you. And I said that on the website that I'm leaving the place better than what I found it because you guys are so good. Now the question is, we have to find somebody who can do a 2-hour workshop for us. But this is not rocket science. This is not rocket science.
Yes, sir.
You have to just start doing it. Just start.
There are also very limited people interested in the field of headache in the city of Mumbai.
No.
I was talking to Ravi.
When the headache specialists are not doing it on a daily basis, please. They're going into Botox. These are phenobarbital gang. What is the problem with Botox is money. So this is cost a few rupees. Come on now.
Jimmy, what do you think?
I have actually not used Botox for any patient with intractable headache. Somehow.
But what I was going to ask you is, you give it for a lot of these craniocervical dystonias, you know, where you actually specialize.
Yeah.
Do any of them say that their migraines got better?
Well, no, I mean,
you may have never asked them.
It's a good idea.
Have you and your patient been satisfied by treatment of dystonia for Botox?
Yeah, I think many of them are. You know, cervical dystonia, Botox does help. The problems are that, you know, you need high doses, lot of money, you know.
Yeah.
But in cervical dystonias, they do help, you know. But,
worth asking. There must be so many who have migraine. So many people anyway have migraine.
Correct. Because, you know, we are
once you say Botox, the budget goes high.
Yeah.
Phenobarbital DON budget is
correct. No, this is precisely the reason why I have not given Botox for headaches.
No, it's a budget situation.
Because it's, you know, I mean, 35,000, 40,000.
Immediate nocebo.
And that too for a procedure where, you know, you can't even guarantee success, you know.
But a lot of people must be doing it, no? For headache?
No.
I think Ravi Shankar must be doing, no?
No, he himself doesn't. Botox for headache. Ravi doesn't.
He does.
Okay.
SPG blocks, sir.
Yeah.
SPG blocks, I have asked Dr. Kritika Doshi, who is a pain specialist. She comes to Thane for a patient of intractable trigeminal neuralgia. So again, you know, the way actually they have to explain all the pros and cons to the patient and the caregivers. It can cause this, it can cause some complications. So one of the patient, you know, just refused that I will not take it. Otherwise, she told me that it's a very simple procedure, and with a reasonably good outcome. So probably we are using less, sir. Actually,
and as usual, there will have to be people identified who go over the learning curve, and then they get that. Otherwise, everybody is in the learning curve with this large city where everyone does everything. Yeah.
True, sir.
Yeah. Jimmy, please do ask about this. I'm very curious.
You see,
I'm very curious.
I mean, they come with a specific purpose. And
I know.
also never asked.
No, you must not have entered. But I'll tell you why. Another reason for asking this. I'm very intrigued by the fact that you tell a patient what a drug will do, and the drug will do that.
Yeah.
Like you give beta blocker for migraine.
Correct.
Has any patient come back saying that my blood pressure is going low?
No.
But you tell them, oh, this is for blood pressure, their blood pressure improves.
Correct.
It's a huge question in my mind. How do drugs work?
No, but you know, the other interesting thing is that when I give the Botox for the focal cervical dystonia, the first thing that improves is not the involuntary movement. The first thing that improves is the pain. The pain of the dystonia goes away first before you know, the movement improves.
And what's
So-
the lag?
I'm sorry.
What's the time gap?
Well, I mean, I give the Botox, the cervical, and maybe in a week or so, they say that the pain is less, but the turning of the involuntary neck movement may take 2-3 weeks
Then you should
before
write it
it
up.
starts improving.
Then you please write it up. If you don't, I will write with your help.
Absolutely.
No, I think these are the points to make. Now, what is the mechanism of pain? I mean, there are so many dystonic patients who don't have pain, and there are so many who have pain.
Right.
Yeah. So, any other question, comment, or we go to the last one?
Sir, even Botox have been used in patients of refractory neuropathic pain, diabetic neuropathic pain with severe burning, and they give shots in both the feet, and patients are okay for a couple of months. So Botox actually seems to be extremely good, sir.
Like minocycline is tried in everything under the sun. You see drug trials for various things, minocycline will appear. I never understood how minocycline appears everywhere. Similarly, Botox seems to appear everywhere. Yeah. But it's also possible that we are underusing it. Right. So we go to the last one now. Yeah. Any other comments on the previous one? Azad, you are planning to take up any of these procedures? Worth thinking about, no? Because we have to go, we have to move up.
Pick up the simple ones.
Take a simple one and then have
I'll
a
work on it.
project. You have DNB people with you.
Immediately get good at it.
Would be nicely documented.
Okay. Yes, sure. Yes.
Right. So I'm doing a short talk now on intracranial hypotension, and I'm doing this as a case-based review of the patient that I have seen over the years. So to introduce the topic, it's a somewhat underdiagnosed etiology of new onset headaches, because often it requires a good MRI backup to tell you what is the diagnosis. The entity was coined in 1938 by a German neurologist, Georg Schattenbrand. Now, I am quite curious as to how in 1938 he must have diagnosed this. I think he must have noted the clinical features, that there are people who become better on lying down and become worse on sitting. But the term was diagnosed first in as far back as 1938. What are the clinical features? Classically, it's postural headache. It's relieved by lying down. It worsens on sitting or standing upright. And in some patients, there is associated nausea, vomiting, vertigo, photophobia, phonophobia, blurred vision, tinnitus. So see that it crosses, the symptoms cross with the migraine headaches, but the posture component is very strong. And there is an occasional patient in which the postural component is not very big. And then you will, it will overlap with the diagnosis of a migraine or migraine-like headache. Physical signs are usually lacking. The examination is normal, but some patients have a neck stiffness and pain on neck flexion. What's the mechanism of the headache? Either less production or more absorption of the CSF. So Bell and his colleagues gave various mechanisms as primary, post-operative, post-traumatic, post-lumbar puncture, nerve sleeve tear, secondary to other underlying medical conditions such as dehydration. For a long time, it was believed that primary choroidal dysfunction is the most common cause of spontaneous intracranial hypotension, but now we know more or less certainly that CSF leak is much more common as a mechanism. And the cause often is a trauma, like lumbar puncture, or fall, traction injuries. And in people who are susceptible, small injuries may also do it, like the Marfan syndrome, the Ehlers-Danlos syndrome, polycystic kidney disease, which is dominant, people who have collagen abnormalities. So what's the mechanism? The CSF volumes becomes low, and because the volume becomes low, there is a venous engorgement, reduced buoyancy, and resultant sagging of the brain, and there is downward traction on the brain, which gives to pain, the Monro-Kelly hypothesis. Now, there are ICHD diagnostic criteria for SIH. First is a headache which is developed in temporal relation to low CSF pressure or CSF leakage, or has led to a discovery of the leakage. Second is low CSF pressure and or evidence of CSF leakage on imaging. And the third is not accounted for in any other way by any other ICHD3 diagnosis. So what is an orthostatic headache? Orthostatic headache is a headache which develops within 15 minutes of upright posture and is relieved within 30 minutes of recumbency. Usually it is much faster than that in clinical practice. So I'll take you through some of the cases. A 25-year-old executive had a long-standing migraine. And on that background, he had a 3-week history of increasing headaches, which mainly came when he sat in his office chair and he had to lie down on a couch that was available, and then it would get better. His examination by the company doctor was normal. His examination by a neurologist was normal. And this is his MRI scan, where you can see where the arrows and arrowheads are. The meninges are lighting up. He had a spontaneous intracranial hypotension, and bed rest for 4 weeks resolved the clinical and radiological features. And he actually had a right paraspinal extraarachnoid CSF collection with a communicating tract shown by the arrow. Now, the only history that he remembered was that while he was traveling in a bus and he was holding the bar, the bus suddenly jerked and his whole body was thrown forward and then backwards, and there was pain in the neck. But that was many months before. So we presumed that this was the leak that was doing it. We gave him bed rest. In 4 weeks, he became better. He remained better. But curiously, it took a very long time for this tract to close. And at the end of 1 year also, you could see this tract. But somehow the CSF dynamics had settled down. Second case is a 50-year-old man, new onset diffuse bifrontal and occipital orthostatic headache of 2 months duration. Then he became progressively dull and apathetic and became incontinent. On examination, he was conscious but withdrawn and inattentive. His optic fundi were normal, knee jerks were exaggerated, plantars were extensive. And these were his MRI scans. MRI brain showing diffuse pachymeningeal enhancement, which one of the features that Dr. Darshan pointed out, as seen by the arrow. And there were bilateral thin hygromas, which are shown by the arrowheads. So arrows are showing the pachymeninges, the arrowheads are showing the subdurals over both cerebral convexities. And on the right side, you have a mid-sagittal T1 weighted image, which shows the sagging of the brain. And again, 2 or 3 things that Darshan pointed out. The pontine fullness is gone and the pons has become flat. Pons has become flat. There is a narrowing of the prepontine cistern, both shown by the arrowheads, and the cerebellar tonsils have descended. So these are the features of sagging, which you should look for to make the diagnosis. So this patient had all the features that you describe in spontaneous intracranial hypotension, and in addition, he had a thin rim of bilateral subdural hematomas. We gave him bed rest. It didn't help. He became more drowsy. So an epidural blood patch was given. In 3 to 4 hours, he started saying that he was better. He improved. But on day 4, he again worsened. So because the first blood patch had helped, a second blood patch was given. And then he remained well subsequently. So let's look at the epidural blood patch, which is the most popular therapy for these, and all of us use it from time to time. It has also been around for a very long time, since 1960. It means injecting antylogous venous blood into epidural space within minutes in prone position. It acts as a mass lesion, compressing the dura and raises the intracranial pressure by increasing the CSF volume. Then the blood clots, and the clot seals off a dural hole when present. Now, in many patients, you don't know where is the CSF leakage, and then you would give, there's some sound, there's some mic needs to be unmuted. Some mic needs to be muted. I don't know whose it is. Can everyone please turn off their mics? I don't know whose mic is it. Ashok?
The host can mute everyone, anyone from Intas.
Yeah, please mute. Right, great. Thank you. So when you know where the leak is from, you can sort of direct your blood patch in that area. And now anesthetists can put an epidural catheter and then target where it is. But when you don't know, you do a blind EPB. And then you put the patient on the Tredelenburg table and move the patient up and down so that the blood spreads from lumbar to the dorsal and cervical area. 10 to 20 ml blood is used, but larger volumes can also be used. People can either give in one point or at multiple sites, but most people give in one point at a time. When an epidural catheter is used, the blood can be spread, the injections can be spread out. There are no controlled studies available about antylogous EPB in CSF leaks, but in a very large percentage, as you see, it is successful, and that is the clinical experience of most of us. And it lasts in most of the patients who improve. Sometimes repeat patches may be necessary. Is it a safe procedure? Usually so, but these complications have been documented. Cranial nerve palsies, intracranial hypertension, paraparesis, cauda equina syndrome, arachnoiditis, subdural and subarachnoid hematomas, and pneumocephalus. Some are iatrogenic, some naturally happen. So EPB is one very good and a standard treatment for spontaneous intracranial hypotension when you know where the leak is from, or in patients where you don't establish the leak as well. Now, case 3 is a 35-year-old businessman. He developed neck pain while he was lying on a sofa. So he went to a person and got a massage done, and the vigorous neck massage increased his pain. Pain persisted. Analgesics were used, and then a cervical collar was used. Then from the neck pain, it became a headache. It became generalized, and it started becoming worse when he was sitting or standing. MRI scan with venography showed thrombosis of the superior sagittal and sigmoid sinuses and a small bilateral subdural connection. We treated him with low molecular weight heparin, then oral anticoagulants and aspirin. 2 days later, he developed severe orthostatic headache and required readmission. MRI scan with venography showed no improvement. Over the next 2 days, the headache became continuous and unbearable. And this is his imaging, showing subdural hygromas, poor flow in the superior sagittal sinus, anterior subdural CSF collection, and the subdural hematomas had increased. So probably the reason for increase in the symptoms was accumulation of blood in the subdural space. So subdural was drained, bed rest was given, hydration was provided. Thrombophilia workup came back negative. 1 month of conservative treatment relieved his symptoms, and a small thin SDH remained at the end of 1 month. So what are the lessons learned from this case? Neck manipulation can lead to a CSF leak. If a subdural hematoma develops, the characteristics of the headache may change, and then the original diagnosis may become obscure. The orthostatic nature may go away. Venous sinus thrombosis is known in patients with SIH. And the pathophysiology is venous stasis, vascular distortion, and CSF depletion. So these are the lessons from case 3. Now, case 4, a 26-year-old female, 10 days of headache, bifrontal, dull, continuous, followed by 2 days of vomiting and 1 day of sixth nerve palsy. CT brain was done, which was normal. CSF attempted because somebody thought of meningitis, but they could not obtain any fluid because the fluid was under very low pressure. So what are the simple lessons from this case? The MRI showed features of SIH. Cranial nerve palsies could appear early, and you may mistake the diagnosis to be something else. And headache may not have the typical characteristics in all the patients. Case 5 is a 36-year-old Reliance supervisor whose job was to inspect factories and therefore took many flights a week in a small 8-seater private plane. His orthostatic headaches began after a bumpy flight 1 month before presentation. Hence, he was admitted in workup. His CSF was 110 mg/% protein, 38 cells, with the sugar being normal. With this CSF, he was started in a hospital on anti-tubercular treatment, and then he was transferred to Bombay Hospital. We wanted to do another CSF. Actually, his CSF pressure originally was not measured, and we did an MRI which showed features of intracranial hypotension. We gave him a blood patch, and there was a relief. The lesson is CSF can exhibit protein rise and cellularity due to altered CSF dynamics, and don't mistake it for meningitis. Case 6 is a 51-year-old male, 3 years of progressive left upper limb weakness, 2 years of right upper limb weakness, and normal sensations and normal lower limbs. So a bibrachial paresis, asymmetrical. Examination showed a pure motor lower motor neuron syndrome with C5 to T1 segments being affected, normal sensations, normal sphincters, normal lower limbs. CK 184, EMG nerve conduction study is favoring an anterior horn cell disease. So the provisional diagnosis with which he was sent to me was a bimelic motor neuron disease. And this is his MRI. He came with this MRI, and then we repeated another MRI. So you can see here, anterior to the spinal cord, you can see CSF collection. This is reverse of the Hirayama disease. And here you can see the CSF collection so beautifully, anterior to the spinal cord. And here is the contrast CT myelography, and you see how the CSF has collected. See the extent of the CSF collection anteriorly. So we went back to the history. Why is the CSF collected anteriorly? Patient had a fall and pain in the neck 3.5 years ago. The fall was from a ladder, and it was significant. He had developed orthostatic headaches and had to lie in bed for 15 days. He never saw a doctor, either for the fall or for these headaches. The headaches had settled down, and the shoulder weakness had gradually developed. So this process started as intracranial hypotension, and then the fluid got localized in the anterior part of the cervical spinal cord. And this is a case of the short form I always forget, ventral subarachnoid CSF collection, which Dr. Neeraj Kumar has been discussing quite a bit. What can these SIH patients be misdiagnosed for? Aseptic meningitis, subarachnoid hemorrhage, plain subdural hematoma, without realizing that subdural is a result of SIH. When the cerebral tonsils are down, you may mistake them for KRE1 malformation. And secondary to intracranial hypertension, shunt overdrainage. So I think in this case-based review, we have gone over some of the points. When the presentation is with orthostatic headaches, the diagnosis is easy. MRI further makes it easy by showing characteristic features. CT scan can miss the diagnosis. Meningitis, subdural hematoma, subarachnoid hemorrhage, and venous sinus thrombosis form differentials and are also complications of this entity. Rest and the epidural blood patch help a large proportion of patients. Subdural hematomas need drainage carefully, and CVST may need anticoagulation. So, ladies and gentlemen, thank you very much for your attention. We very briefly covered this entity, and it's open for questions, queries, discussion. Thank you. Ashok.
Superb. It's a very, very beautiful. The case-based analysis was absolutely fantastic. Take-home points were superb. Lot to learn. Lot to learn. Yeah.
I think it's often sort of underdiagnosed. No?
I think it's
the key is history. Does it improve on lying down? That's it. That's the key. If you missed that, you missed it forever.
Correct.
And this is something, unless you ask, he says, मैं सो गया आराम किया तो ठीक लगता है. So he doesn't mention it to you.
Correct.
So unless you say बैठ के खराब होता है, सो गया तो ठीक होता है. Unless you ask, key point, direct questioning, no Hutchison Hunter, direct questioning. That's the only way to get it out.
Sir, fantastic cases, sir. Wanted to ask, we have a patient who developed post CSF leak because of the Carey malformation, ultimately developing a obstructive hydrocephalus and papilledema at JJ. And I mean, this young lady had a typical orthostatic pain few months back. After that, she was okay at home. Now she came with raised ICP.
Yeah.
And there is a significant obstructive hydrocephalus.
Yeah. Like I showed in the presentation, sometimes after the epidural blood patch, some kind of a reaction on the opposite side and hypertension has been documented. So this happened after the patch or naturally happened?
Actually, sir, patch was given. And a few months after patch, she was okay. And now she came with this complaint.
There are case reports of hypotension being treated and then going into hypertension.
Okay.
So in your patient, did you demonstrate the block because of the tonsillar herniation?
Yes, sir. Block is still there. MRI is showing a block, and now it shows the obstructive hydrocephalus and papilledema. And with a severe pain now.
So what's the postulation that there was under treatment of the original condition, and the descent was too severe, and the descent
Most
then
likely.
led to
yes, sir. Absolutely. Yes, sir.
Worth documenting.
So we have sent for actually tapping to the neurosurgeons because the pain is too bad. Now the pain is actually of the raised ICP.
And primarily there was nothing.
Nothing.
Not a case of Arnold Carey malformation developing this due to something.
No, sir. I mean, in the beginning, she had typical orthostatic hypertension. Leak was not seen, but patch was given. And then she was okay for a few months.
Before the leak, there was nothing to suggest an ACM.
No. Not this, sir. Not this.
This
is
secondary.
developed after the patch.
It's quite an unusual, but though documented.
Yeah.
Jimmy, any comments on this peculiar condition?
No, I think it was an extremely comprehensive talk, and your the mechanisms and all what you showed, extremely enlightening and interesting, And as Ashok said, a high index of suspicion is absolutely important. If we don't think of it in our minds, we will definitely miss it.
Yeah. Also, I think just one comment, if I can make, that whenever you see a subdural hematoma, a patient with a subdural hematoma, please keep this at the back of your mind, that the origin of the subdural may be here.
Satish,
Yes.
the other thing is, especially if it is a bilateral subdural.
Yeah. Yes, sir. Yes, sir.
If it's a
Correct.
bilateral symmetrical subdural,
Correct.
I think the chances of SIH will be very high.
Correct. You know, there was one patient whom I remember. He was a Tehsildar in Ratnagiri. And in the government jeep, he used to travel a lot. He developed headaches which did not have the orthostatic character. And a subdural was diagnosed in Ratnagiri. And they said that this needs to be drained. So he came to Bombay. He kept on asking me a question: why have I developed this subdural hematoma? How did I develop this subdural hematoma? Because he was young and fit. He didn't remember any trauma. And then when we repeated an MRI here, it had features of SIH in addition to the subdural. So any subdural that comes to us, we should keep this at the back of the mind, particularly bilateral, like you said.
Would you accept that your statement holds true, especially for older patients? Especially for old, because of the gap and because of what have you?
Possible. Yeah. They may be more susceptible. Yeah.
Yeah.
Also, another point that bilaterality will favor the origin of SIH, but unilaterality doesn't exclude it.
Yeah.
You can also have a unilateral SDH after this. So it's the more likely, less likely sort of thing.
Sir, what is the best way of locating the leak? I mean, you do the CT cystonogram or the MR cystonogram or just a simple MR?
Actually, I now feel that a contrast MR myelography is the best, because you are not disturbing the CSF dynamics in any way. If you want to put a contrast in CT, then you are further disturbing the CSF dynamics. So I'm quite inclined to do MR contrast myelography. But in a lot of people, you cannot diagnose the leak. And in some others, the leak is very easy to diagnose, but doesn't go away in spite of surgery.
And sir, what do you think of the drugs used for the treatment of these headaches? Like people say, deriphyllin and caffeines, and anesthetics have their own preferences.
Actually, I think nothing other than blood patch works.
Blood patch works.
You have to put them in lying down. And it can be a long lying in period, which so many people today just don't accept.
Takes time to resolve it.
So, Jimmy, anything you want to say?
Fantastic.
Oh, it's a peculiar condition. So, Jimmy, you want to make any comments? Then we will sum it up.
No, I think it was. I absolutely enjoyed today's continuum. I think there were so many practical points. I think we've kept the time reasonably well, and I'm extremely happy, and I think I've learned a lot. I think these
discussions, first of all, I think all presenters did a very good job.
I think so. Yes.
Each one was very crisp, clear. The slides were good. So I think in that respect, every continuum is only going higher and higher. And the discussion is, again, the heart of the whole session. So I think we persist with this format. And Azad, can you tell everyone what is the next and the date?
So next
or you will announce.
Yeah, okay. We'll announce.
Right. Great. So those of you who have not yet signed the forms, please sign them, because this is a WFN activity and they want us to really put the forms in. So the form is on the WhatsApp group. Please do sign. And thank you, everyone. And do we close at that? Ashok, thanks for being here. Rakesh, thanks for being here.
Bye, sir. Thank you.
Thanks to all the presenters.
Thank you.
Yep. See you.
Thank you, sir.
Thank you, everyone.
Thank you, sir. Bye.
Bye. Bye. Bye, sir. Bye, sir.
Bye, sir. That's all.